Good morning. Good morning, all the respected teachers. Myself, Dr. Bhagyashree Parira from Off-Screen Jennings, going to represent a paper on a case report, amniotic fluid embolism, which is a diagnostic dilemma. So this is a catastrophic obstetric condition which is caused by entry of the amniotic fluid or fetal antigens into the maternal circulation. It's completely diagnosis of exclusion, which comprises of the symptoms like acute onset of hypoxia, hypotension, seizures and uncontrolled hemorrhage, etc. Regarding timing, it may occur during labor, during or following vaginal delivery, or maybe during cesarean section. Sometimes even it may occur during abortion, after abdominal trauma, or during amnio infusion. So what can be the risk factors for this condition? Those are strong uterine contraction, meconium strain lipid, operative deliveries, placental abnormalities, preeclampsia, eclampsia or Hurd syndrome, or polyhydramnios, etc. Recently, this AFI is known as anaphylactic syndrome of pregnancy, which includes activation of the complement and coagulation system, causing mainly vasospasm, edema, and early onset DIC. So, we are discussing about this case because the incidence is 1 in 8,000 deliveries, while the maternal mortality in AFI has been encountered as 20 to 60%. Unfortunately, most of the patients that we encounter are from the exacerbations of this condition which do not recover in spite of intensive clinical management. So, early diagnosis and prompt interventions is the one which is going to determine the prognosis. So, regarding pathophysiology, I mentioned something. Exposure, after exposure to the amniotic fluid or fetal antigens, there will be massive release of immunological mediators which will lead to mechanical obstruction in the pulmonary vessels. So, acute pulmonary hypertension will first lead to right ventricular failure. At the same time, complement system and coagulation system will be activated leading to congestion coagulopathy, which leads to cardiopulmonary collapse. So, right ventricular failure, after right ventricular failure, most of the patients, they die. Those who survive later, they may develop left ventricular failure. Some people, they have long-term problems like neurological problems like coma, seizures, residual deficits. Some develop acute respiratory distress syndrome or acute pulmonary edema or acute kidney injury, etc. So regarding our case report which we encountered in Jennings, was a 27 years old unbooked case, primary, at 38 weeks of POG, she got admitted in active labor for safe delivery. On general examination, there was no abnormalities detected, vitals were stable, no significant medical or surgical history was there. At the time of investigation, all investigations were normal. Per abdominal examination on term size fetus, so as in cephalic presentation with cardiac activity. On PV examination, also was 5 centimeters at the time of admission. After full dilatation, 4 hours after admission, artificial rupture of membrane was done and labor was augmented with oxytocin. After few minutes, he started having sweating, anxiety. On examination, there was hypoxia, pulse rate was dropping, and respiratory rate was 24 breaths per minute, and the blood pressure kept on decreasing gradually, and on Doppler, fetal heart sound was not localized. So immediately oxytocin was stopped, and after consulting medicine and anesthesia, we started on IV fluids and oxygen supplementation. And after stabilizing the patient due to maternal exertion, ventouse was applied, and the flaccid male baby weighing 3.3 kg was delivered, who didn't cry immediately after the birth, was attended by the pediatricians and was admitted in NICU for birth asphyxia. So total duration of second stage of labor was 60 minutes. Post-delivery, there was a huge amount of bleeding noted from the uterus. All the uterotonics were given, but in spite of that, bleeding didn't stop, and we went for intrauterine balloon tamponade, and by the same time we started on PRBC transfusion. Still, vitals and bleeding didn't improve, and uterine atony was noted, and our obstetric team decided to go for exploration in OT, and on exploration, flabby uterus was noted, and emergency obstetric hysterectomy was done under GA. So total intraoperatively 9 PRBC, 8 FAP, and 4 platelets were transfused. Patient was transferred to ICU with intubation and vasopressors, was kept on multidisciplinary management, and multiple blood transfusion was done. She was kept under broad-spectrum antibiotics, and vasopressors were gradually tapered, and she was finally extubated on the post-operative day 5. Her renal parameters were worsening, for which 3 times alternate day dialysis were done. Gradually her blood parameters improved, and the patient was discharged, improved and discharged on the 16th post-operative day without any complications. On investigations at the spot, when we sent for AVG, there was hypoxemia features, and ECG was showing tachycardia and ST segment in T wave changes. There was T inversion in the V1 to V4 leads, showing right ventricular stain pattern, and in blood test there was anemia, thrombocytopenia, and protein time was found to be prolonged. So PRBC, platelet concentrations, and FFP was given. And APTT was found to be within normal limit. Her LFT was within normal limit, but KFT was varying. So her serum urea creatinine in the post-operative days were on a rising call, so dialysis were done. Bedside chest X-ray, which was done in POD3, was showing diffuse bilateral heterogeneous and homogeneous areas of increased opacity. She was kept on ventilator support, nebulization, and mucinate infusion. Bedside echo was done, and it was showing left ventricular hypokinesia and cardiomyopathy. Bedside ultrasonography was showing mild hepatomegaly. Both the kidneys were enlarged in size with diffuse hypoechoic areas. So regarding discussion, is a diagnosis of exclusion, which is very difficult to diagnose. The reason that leads to poor prognosis is due to late diagnosis only. And the presentation can be typical symptoms or atypical. The typical will follow the phases like cardiopulmonary collapse, coagulation disturbances leading to multi-organ dysfunction, neurological complications, etc. But the atypical will present either as like uterine hemorrhage or ARDS, any one of those features only. So regarding any cardiopulmonary collapse which occurs during obstetric management, we should keep those differential diagnoses in our mind, like air embolism, it could be pulmonary embolism, it could be AMI, septic shock, eclampsia, uterine rupture, cardiomyopathy, and it may be abraxia, or it may be due to anaphylaxis to the anesthetic drugs also. So, in our case, there was no history of high blood pressure for the patient. It was not anemic prior to delivery. The associated risk factors may be the amyotomy, augmentation of labor, fetal distress, and operative delivery, and male baby, which is also one risk factor for AFE. So, sudden onset was favoring, and the labor breeding was favoring in the term of AFE. So, we went on this line of management. So, initial phase will be like right ventricular failure. If it could have been available, then transthoracic echocardiogram could have been done, but we could not do. And CT angiography and ventilation perfusion scan also can rule out pulmonary embolism, which was not done in our case. So survival is mainly due to early recognition and management. Probable sequelae will be neurological impairment, multi-organ dysfunction. Infant survival rate will be like 70%, and there will be neurological impairment to the both mother and baby. But the time elapsed between maternal arrest and delivery is very important, so that we can act on time. So, high index of suspicions would be there in any intrapartum or postpartum collapse, in which cause we cannot identify. So, it's a life-threatening condition which can be reversible if we intervene early to reduce the maternal mortality. So, to prevent this condition, we can avoid the trauma to the uterus during maneuvers, controlling strong and frequent uterine contractions, and judicious use of the uterotonics we can do to avoid this event. These are the abbreviations and references I included. Thank you.
Thank you, Dr. Bhagyasri.
Yes, ma'am.
My question is, what is the novelty of this presentation?
Ma'am, actually in our hospital also when this case happened, it was a very rare case and a sudden cardiopulmonary collapse, and we could not find any cause. It was not having any risk factors also. So later all the findings which was going in the line of AFE. So we should keep in this case, we should keep in our mind if for any collapse, cardiopulmonary collapse happening in a interpartum or postpartum, so that we can act on time.
Hello.
Yes, sir.
Bhagyasri?
Yes, sir.
Hepatic fluid embolism is a nightmare of all the obstetricians, no?
Yes, sir. We also
what precautions you would like to take to minimize the mortality?
Sir, as I mentioned, we should judiciously use the uterotonics, and we should monitor frequently heart rate and the contraction to avoid more contraction. And during amniotomy or amnioinfusion or any maneuvers, we should be very careful. That's all we can do, but it's incidental, it can happen with anyone.
It's critical time, no? You have to watch for the possibility of amniotic embolism.
So during any procedures which is disturbing uterine during delivery also, or maybe during any maneuver, or in second trimester also when you do amniocentesis and all, also it can happen. So all these times we should be very careful.
Okay, thank you.
Thank you, sir. Thank you, everyone.
Next, please come up Dr. B. Kumar. Topic is evolution of erythrocytosis in adult in a tertiary care hospital journey.
Good morning, everyone. Today I am going to present the evaluations of erythrocytosis in adults in tertiary care hospitals. I am going to present under the following headings. As we all know, erythrocytosis or polycythemia is an abnormal increase in various volumes or hemoglobin in the peripheral blood. Erythrocytosis is divided into two types: relative or spurious and absolute erythrocytosis. So in relative erythrocytosis, there is no blood cell counts in the bone marrow, and there is elevated hematocrit levels due to decreased plasma volumes. Dehydration, diabetes, and diarrhea, these are some causes that lead to decreased plasma volume. So in absolute erythrocytosis, there is increased red blood cell productions in the bone marrow. There are two types of absolute erythrocytosis. One is primary erythrocytosis and a secondary erythrocytosis. Here the hemoglobin and hematocrit levels are increased, but the erythropoietin levels may be increased or decreased. So in a primary erythrocytosis, usually results from the acquired or inherited mutations in genes. So there are two types of, again, primary erythrocytosis, polycythemia vera, and primary females and inherited polycythemia, usually results from the erythropoietin receptor mutations. So in this primary erythrocytosis, the hemoglobin and hematocrit levels are increased, but the erythropoietin level is decreased. So polycythemia vera is the most common primary erythrocytosis. It usually results from the clonal stem cell disorders that lead to increased productions of red blood cells in the bone marrow. There is slight male preponderance, and the median age of orientation is 60 years. So in order to diagnose the polycythemia vera, 3 measures or 2 measure plus minor criteria is required according to the 2017 revised editions of the ratio classifications of tumors. These are the major criteria and the minor criteria: subnormal serum erythropoietin level. Secondary erythrocytosis, there is increased red blood cell productions in the bone marrow due to increased erythropoietin levels. These are some acute conditions that lead to increased erythropoietin levels. Hepatocellular carcinoma and cell carcinoma, these are the disease conditions that lead to increased erythropoietin levels and ultimately to increased basic productions. And here the conditions like high oxygen effective hemoglobin and congenital methemoglobinemia, these are the conditions that lead to increased erythropoietin levels. And there was few studies conducted to evaluate the spectrums of erythrocytosis. Hence, this study has been undertaken with the aims to evaluate the prevalence of erythrocytosis in adults in the tertiary care hospitals. It's a retrospective cross-sectional studies conducted in Jennings hospitals. 2 years data were collected from the registers maintained in the medicine and pathology departments, and all the patients aged 15 years and above with persistently high hemoglobin levels were included in this study. And the reports of complete hemograms, reports of bone marrow, and reports of molecular and genetic analysis were collected for analysis. A total of 95 cases with high hemoglobin levels were found for the study. All of those, only 88 cases were included in the study, and all of 88 cases, again 63 cases, were found to have secondary erythrocytosis. And 25 cases didn't have any known cause. Bone marrow examinations and molecular genetic analysis reports were collected for further analysis. This graph, this table shows the total identified cases having high hemoglobin levels, and this also shows the distribution of secondary erythrocytosis, whereas secondary erythrocytosis are far more common in the age group of 60 years and above. And this also shows the distribution of secondary erythrocytosis by genders. So it has male preponderance. And this is the distribution of secondary erythrocytosis by etiology. Most of the cases had a respiratory disease followed by the cardiac problems. And the 25 cases didn't have any known cause. So bone marrow examination was done in these 25 cases. This is the bone marrow finding of all the 25 cases. Hyperosmolarity was found in 16 cases, and normal necrosis were found in 16 cases, and erythropreponderance were found in 11 cases. Again, the molecular genetic analysis of all the 25 cases was done, and out of these, 40% had JAK2V617F mutations were found positive. And serum erythropoietin levels, 40% of the serum erythropoietin levels was found below subnormal. So only 10 cases out of 25 fulfill the criteria of polycythemia vera. And the polycythemia vera is found to have female preponderance in my study. So to conclude, secondary erythrocytosis is the most common erythrocytosis in adults with male preponderance. And the polycythemia vera is found to be more common in females. So polycythemia vera should be properly diagnosed, as these cases usually present with thromboembolic phenomena. So further study is needed, as this area is relatively unexplored. Thank you.
Kumar,
Sir.
What is the significant finding which is different from the other previous studies? In other words, what is the rationale of presenting this paper?
The significant finding is in other studies, polycythemia vera is more common in males, but in my finding, it is more common in females. It may be due to less cases.
The paper is very interesting, Dr. Bir Kumar. Of the 25 cases were primary, you said, right, in the findings?
So 25 cases had no known cause.
Had no known cause?
No known cause. So we did the bone marrow examination. They did bone marrow examinations just to find out the primary cause.
Okay, of the 10 were polycythemia vera?
Yeah, of the total 25 cases, 10 were found to have primary polycythemia.
What about the 15? What about the remaining 15? Did you find any?
And the remaining, sorry, sir?
Of 25.
Okay.
See, of all your studies, I think most of them were due to secondary causes. 25 did not have a known cause, right?
Yes, sir.
Of these 10 were polycythemia vera.
Yes, yes, sir.
What about the remaining 15?
Oh, yes,
you don't
15.
describe that at all.
The remaining 15 cases had neither this JAK2V167F positive, neither JAK2 positive. So further study is required just to assess the cause of erythrocytosis in these 15 cases.
Bekumar, taking a cue from your study, what further study would you like to do?
We need to have some more molecular study just to rule out this polycythemia vera. Thank you.
Next competitor is Dr. Kanchan.
Good morning, respected sir and madam. My topic today is functional outcome of conservative management of displaced mid-shaft clavicle fracture and its significance during the COVID-19 pandemic. Clavicle fracture is one of the most common fractures that we encounter in our orthopedic practice, accounting for 2.6 to 10% of all fractures, and 80% of this occur in the midshaft, and 50% of this are usually displaced fractures. Clavicle fracture causes problems like pain, fatigue, loss of strength, and subacromial impingement in the involved shoulder, resulting in significant functional loss in the patient. The aim of my study was to assess the functional outcome in relation to shortening of the bone and treatment satisfaction among the patients with displaced midshaft clavicle fractures who were managed conservatively during this COVID-19 pandemic. My study is an analytical cross-sectional study among the patients who presented in our casualty from March till November 2020 who were managed with a figure of 8 bandage. The sampling method was universal sampling, and the sample size we got was 20. The patients were followed up at an interval of 2 weeks, 6 weeks, and 3 months from the day of injury. Inclusion criteria included all patients with displaced middle third or mid-shaft clavicle fracture. Only the fresh cases were taken, and the age was from 18 to 60 years. Exclusion criteria included pathological fractures, non-union or malunion cases, neurovascular injuries, open fractures, bilateral clavicle fractures, and cases in which there is any pathology that impairs the function of either of the shoulders, or any patient who did not give consent was excluded. We took the demographic profile including the age, sex, occupation, clinical history, and other clinical data. Standard APV chest X-ray including bilateral shoulders were taken. Constant Murley score was used to assess the functional outcome, and it was recorded for both the injured as well as the normal side, and treatment satisfaction was determined using a questionnaire, and the data we collected was analyzed using SPSS version 22 software, and a p-value of less than 0.05 was considered statistically significant. Figure of 8 bandage was used to immobilize the fractured clavicle, and the period of immobilization ranged from 3 to 4 weeks, following which they were advised to do physiotherapy including pendulum exercises. The constant Murley score is used to assess the functional outcome. It has 4 variables that measures the pain, function, range of movement, and the strength. It is measured for both the upper limb, and the difference was taken between the normal and the abnormal side, with a score of a difference of more than 30 being a poor outcome, 21 to 30 being a fair outcome, 11 to 20 being a good outcome, and less than 11 being an excellent outcome. Shortening was measured by using X-ray of bilateral shoulders, in which we drew a straight line through the medial point from the sternal to the acromial border of the clavicle, and we compared the difference. In our study, all our patients had good functional outcome with a constant Murley score mean of 76.90 with a standard deviation of plus minus 3, and a mean shortening length of 15.65 mm was seen with a standard deviation of 2.94 mm. There were no cases of non-union. This is an X-ray showing a midshaft clavicle fracture with significant displacement in a patient who had suffered from this injury during an road traffic accident. The above picture shows a bulging callus formation in the patient who were treated conservatively at 6 weeks follow-up, and the second X-ray shows a united fracture clavicle at 3 months follow-up. Majority of our patients were male, constituting 70% of the total sample size. Mode of injury most common was road traffic accident followed by fall from height. Mostly non-dominant side was injured, and 90% of my patients had treatment satisfaction. After performing a logistic regression analysis, the clavicle shortening was found to be associated with a constant Murley score, and it was found to be statistically significant. This is a scatter plot showing the correlation shape between a constant score and the shortening, showing that with less shortening there is a better functional outcome. Conservative method is a traditional method of treatment of a clavicle fracture. Literature, however, reports high non-union rates and a relatively poor functional outcome. Robinson et al. Had reported a non-union rate of 21%. Another meta-analysis study conducted from 1975 to 2005 had reported a non-union rate of 15%. However, contradictory to this, Mayer et al. And Lower et al. 1960 and 1968 had reported a very low non-union rate
of 0.13% and 0.8%. However, in our current study, there were no cases of non-union, which may be attributed to the fact that our study had certain limitations, like short period of follow-up and low sample size. Escola et al. Had identified 15 mm shortening as a threshold value above which pain was likely to be present. Hill et al. Reported unsatisfactory results with bone shortening of more than 20 mm. In our study, the mean shortening was 15.65 mm, better functional outcome being observed with lesser shortening. Only 2 male patients, constituting 10% of my sample size, complained of pain and loss of strength at the end of 3 months. This satisfaction was more among male patients and whose occupation was physically demanding. Both of these patients had a shortening of more than 15 mm. Surgical treatment is a more popular method of treatment. Literature reports a lower non-union rate and better functional outcome with certain indications including open fractures, which is an absolute indication, and other relative indications like displacement from more than 2 cm, shortening of more than 2 cm, comminuted fractures, and impending open fractures with soft tissue compromise. Then came the COVID-19 pandemic, and the whole scenario changed. There were various guidelines given for the Indian Orthopedic Association, the British Orthopedic Association, which told us to focus on the pragmatic management, balancing the optimum treatment of patients against clinical safety with resource utilization, and our aim should be to minimize the risk of viral transmission by avoiding aerosol-generating procedures and use of personal protective equipments. In our conclusion, conservative treatment methods, as shown by our study, give good functional outcome with less complication. Conservative methods still have a significant place in the armamentarium of fracture management, and it provides a good means for managing various orthopedic injuries during this pandemic scenario. The final take-home message I would like to say is that not all fractures need surgical intervention, and let us revive the forgotten art of conservative management of fractures. These are my references. Thank you.
In your setup, Dr. Kanchana, had it not been for COVID times, would the approach have been different or not?
Then I would stick to the conventional indications for surgery, and I would further segregate the patients. If the patient fell into the category that required surgery, I would definitely go for surgery, and those that fall into the category which may be managed conservatively, I will definitely go for conservative treatments.
Thank you.
Thank you, ma'am.
Kanchana, congratulations. All the 20 patients of yours, all there were no non-union cases, unlike the other studies you have, this one, quoted.
Yes.
What may be the reason you want to cite why it is so, and you have, right now you have said that it is because of the COVID you have gone for the conventional method. Otherwise you could have done some surgical intervention in some of them.
Yes.
So in future post-COVID period, you will prefer the conventional or surgical intervention of such cases? 2 questions.
Sir, that depends on the indication. If a patient presents with compound fracture that is open fractures, I cannot conserve the patient. I'll have to go for surgical intervention, sir. So it depends on a patient's presentation also, sir.
Okay. In these 20 cases, some of them were indications for surgery, you did not do for that, and
Yes,
you
sir.
went for conventional.
Yes, sir. Some patients had a displacement of more than 2 mm, and we had included them in the study, and those also had a good functional outcome, even though the sample size was low.
Okay, thank you.
Excellent paper, Dr. Kanchana.
Thank you, sir.
I have seen that you are using the Krebs elastic bandage.
Yes, sir.
But in the market, we have a lot of custom-made fracture clavicle bandages.
Yes,
Which
sir.
one would you prefer?
Sir, I think we should go forward with this Krebs bandage only because it is an elastic bandage and it provides a greater lifting effect on the shoulder and greater stabilizing effect. Those that we get from the companies, for example, those different companies, they are sometimes not fitting the patient, tend to get loose, and the patient used to remove it easily, so that the immobilization is usually not effective.
How often do you have to tighten the bandages?
Sir, we tighten the bandage at every visit, sir. every follow-up visit, 3 times we had called them and we had tightened them.
Thank you very much. Well presented.
Thank you, sir.
Thank you. Next, we will call upon Dr. Singh Tongbing.
A very good morning to my dear teachers and my dear colleagues. I am Dr. Tongbing Wangleiching, Medicine PG from Jennings, and I will be presenting on my thesis paper titled The Prevalence of Thyroid Disorder in Patients of Acute Coronary Syndrome Admitted at Jennings. I do not have any financial disclosure for my paper. And coming to the introduction, it is well known that cardiovascular diseases are one of the leading causes of morbidity and mortality in the world. And there are many risk factors, traditional risk factors like hypertension, dyslipidemia, diabetes mellitus, obesity, smoking, which are well studied. However, the role of thyroid hormone in initiating and exacerbating cardiovascular diseases are lacking. That's why this study is done, to see any association between cardiovascular disease and thyroid disorder. The primary objective of this study is to study the prevalence of thyroid disorder in patients of acute coronary syndrome in Jennings, Manipur. And the secondary objective is to compare the adverse clinical outcome of SCS patient with thyroid disorder and SCS patient with euthyroid. It is a descriptive cross-sectional study for a duration of 2 years, and we have included those patients aged 18 years and above who have been diagnosed with SCS by chest pain consistent with at least ECG changes and enzyme elevation. And we have also excluded those patients who are on medication that are known to cause thyroid dysfunction, like amiodarone, lithium, iodinated contrastenol. Those patients were excluded. And we also have excluded those patients who are on anti-thyroid drugs for both hypothyroidism and hyperthyroidism. We have also excluded those patients who have undergone thyroidectomy and those patients of decompensated liver and kidney disease. Our study variables is mainly thyroid profile in the form of free T3, free T4, and TSH, and outcome measures. The normal biological reference values taken was TSH, 0.27 to 4.5 milli-international unit per liter, free T4 3.5 to 8.5 picomole per liter, free T3, free T4 10 to 28.2 picomole per liter, and according to the thyroid profile, the patients were categorized into euthyroid, subclinical hypothyroidism, subclinical hyperthyroidism, clinical hypothyroidism, overt hyperthyroidism, and euthyroid 6 syndrome. And after collecting data according to the proforma and getting ethical clearance from the ethical committee, statistical analysis was done with chi-square test and t-test, and mean, median, and percentages were used wherever necessary. So this is the results that we get from our study. In the first figure, in the y-axis, we have the percentage of patients, and in the x-axis is the age in years. As we can see here, in the older age group, more than 60 years, it comprises of 63%. That means ACS is more common in the older age group. And in the second figure, we can see it's a pie chart showing the age distribution of respondents. As we can see clearly, the green area denotes the male sex, while the red area denotes the female sex. That means male sex predominate in SCS. That is what we observed from our study. And in figure 3, we have, other than thyroid disorder, we have studied what are the other risk factors that are common for SCS. And we have found that hypertension here, as we can see here, hypertension with 53.7%. It is the maximum risk factors that we have observed in SCS patients, followed by chronic smokers and then diabetes. And in the figure 4, we have a pie chart showing the types of acute coronary syndrome. And as we can see here, ST elevation MI with 56.5% is the maximum, followed by non-ST elevation MI with 36.1%, and unstable angina with 7.4%. So we have come to our primary aim and primary objective, and our finding is the prevalence of thyroid disorder in SES patients, and we have found that the thyroid dysfunction is about, as we see here, 25.9%. We have observed that 25.9% of our SES patients, out of 108 patients, 25.9% have thyroid dysfunction, and 74.1% have euthyroid. And out of the 25.9%, what we observe is that maximum is comprised by euthyroid 6 syndrome. That is either normal TSH with low T3 or low T4, which comprises of the maximum, and followed by hypothyroidism with 7.4%, and then subclinical hyperthyroidism and subclinical hypothyroidism, both comprises about 2.8%, and hyperthyroidism, overt hyperthyroidism with 1.9%. And this is the secondary, objective that we have, and this is what we observe. If we see here in this figure, the first figure is for thyroid dysfunction, and the second figure is for euthyroid. And what we can see here is clearly this one figure in red. This figure in red shows the adverse clinical outcome. We have measured in the form of left ventricular failure, cardiogenic shock, or high-grade AV block, or arrhythmias, and even death. 2 patients have died, and both are from the thyroid dysfunction with ACS group. So like it is clearly seen here from this diagram that 28.6% of the patients have adverse clinical outcome in thyroid dysfunction group, whereas in the euthyroid group, around 11.2% have adverse clinical outcome. And it is statistically significant with a p-value of 0.037. And in our case study, in our study of 108 patients, we have found that, we have observed that the prevalence of thyroid disorder is 25.9%, with the maximum comprised by euthyroid 6 syndrome with 11.1%. And we have also observed from this study that the adverse clinical outcome in the form of left ventricular failure or cardiogenic shock or death is more common in acute coronary syndrome with thyroid disordered patients, which is statistically significant. So what this paper, what this study has taught us is that thyroid profile should be examined in acute coronary syndrome. We often, examine the hypertension, diabetes, or dyslipidemia, but we often forget the thyroid profile. But it shows that it is very important. Thyroid profile is very important for acute coronary syndrome, and many literature have shown us that thyroid dysfunction, especially in the form of euthyroid 6 syndrome, has a very great prognostic, is a great prognostic indicator for acute coronary syndrome patients. And as our theme is living with COVID-19, ACS, acute coronary syndrome or myocardial infarction, due to its thrombogenic nature, is a well-known complication of COVID-19, because one of the most important pathophysiologic mechanism for COVID-19 is thrombosis. So ACS is a very common complication for COVID-19. Thank you.
Excellent paper, Dr. Tombing.
Thank you, sir.
I think it's very significant finding that among those who are not of normal thyroid status have a very poor prognosis in comparison to.
Yes, sir.
It's an excellent finding.
Yes, sir.
I find that in medical specialties, most have started writing thyroid hormone profile as a routine investigation, but the surgeons still have not picked up yet. I think this is something we should learn.
Yes, sir.
But my question is, what is the number of, or the prevalence of thyroid disorders in normal population, not with the not in the ACS group? Have you studied that or not?
Sir, the thyroid dysfunction in not SCS patients in normal individual. In sir, actually I didn't look up, but I think it's around 20%.
Like you found that around 25% are
Yes, sir.
thyroid disorders. But if there are many in the normal population who are not euthyroid. So do you know how much? Because we find in gynecology there are presentations in pregnancy. They're testing now. A lot of thyroid profile disorders are found. So have you compared with the normal population or not? There is
No, actually, sir, I didn't compare with the normal individual. I have studied only in the SCS patients, so comparison was not done, sir.
Tombing, it was a very good paper.
Thank you, sir.
The outcome is also surprisingly very significant.
Yes.
Can you explain the relationship? Why?
Because, sir, this one, like what they found is that, sir, according from my review of literature, what I found is that what the literature say is that euthyroid 6 syndrome is the has the most poor prognosis in acute coronary syndrome patients. That is actually, it is a non-thyroidal illness. Means like when the patient have inflammation or acute trauma, then there is decrease in peripheral conversion from T4 to T3. T3 is actually the active form. That's why there's the decreased conversion from T4 to T3. So this one, that's why the euthyroid 6 syndrome is there. That means that it teaches the extensiveness of the whatever the patient's primary disease is. For example, it could be SCS, or it could be trauma or surgery or anything. Like so, it tells the extensiveness of that inflammation or that injury. Means the euthyroid 6 syndrome tells actually. So euthyroid 6 syndrome has it is used for prognosticating the SCS patients because it tells the extensiveness of the primary injury other than the SCS, mainly.
Okay, thank you.
Tombing, when there is worse outcome in patients with thyroid diseases,
Yes.
have you looked for any other confounding factors that could have contributed to this not so good
Ma'am,
outcome?
actually, in this study, no other confounding factor was looked for. I should say. Thank you.
Next final competitor for this session is Dr. Rachel S.
Good morning, my respective judges, dear friends and faculties. The topic which I am going to present today is serum endoglin in preeclampsia. Coming to the introduction, endoglin is a 180 kilodalton homodimeric transmembrane glycoprotein consisting of 633 amino acid. It is a cell surface co-receptor of transforming growth factor TGF beta 1 and beta 3, and is highly expressed on the endothelial cells, syncytial trophoblasts, endometrial stromal cells, and hematopoietic stem cells. The soluble circulating form, which is the S-endoglin, is produced by the proteocleavage of placental membrane-bound form in the extracellular domain, and it is an anti-angiogenic factor which is implicated in the pathogenesis of preeclampsia. Preeclampsia is a specific pregnancy-specific syndrome characterized by newly onset hypertension and proteinuria, and is usually occurs during the second half of pregnancy and remits after delivery or termination of pregnancy. It is diagnosed by the blood pressure of more than 140 systolic and more than 90 diastolic on 2 occasions at least 4 hours apart after 20 weeks of gestation in previously normotensive women. and a proteinuria of more than equal to 300 milligrams per 24 hours urine collection or more than +1 by dipstick method. The incidence of preeclampsia is about 5 to 7% of all pregnancies, and according to the WHO, the incidence is 7 times higher in developing countries than in developed countries. As we can see in India, which is a developing country, it is around 10%, and in USA, which is a developed country, it's around 2.5%. There are various studies which have been shown that endoglin plays an important role in pathogenesis of preeclampsia, but no study has been done in this part of India. So this study was planned to assess whether there is any association between endoglin and the pregnancy outcome in preeclampsia. The aims and objectives of this study was to evaluate and compare the level of serum endoglin in preeclamptic women and healthy pregnant women, and to correlate the serum endoglin levels with the blood pressure. Coming to the materials and method, the study design was a case control study. Duration of study was 2 years. The study settings was done in the Department of Biochemistry in collaboration with the Department of Obs and Gynae RIMS Imphal. And the study population was a total number of 60 subjects, 30 diagnosed preeclamptic women and 30 healthy controls. Study tool measurements, serum endoglin was measured by ELISA test. Statistical analysis was done by SPSS version 21, and p-value of less than 0.05 was considered statistically significant. The inclusion criteria were in the cases we had preeclamptic women aged more than 18 or equal to 18 years old admitted in the antenatal ward and willing to participate in the study, and the controls we had the normotensive pregnant woman with no proteinuria admitted in the antenatal ward. The exclusion criteria were chronic hypertension, diabetes mellitus, multiple pregnancies, renal diseases, smokers, and neoplastic diseases. The study was approved by the Research Ethics Board RIMS Imphal. Coming to the result, as we can see here in this bar diagram, more the cases were seen in the age group of more than 35 to 40%, which showed that the more the age of the mother, the occurrence of preeclampsia was higher. And in these scatter plots, we see that the correlation between the systolic and diastolic BP was significant, with a Pearson correlation of 0.819 in the systolic blood pressure, which showed that by the increase of systolic blood pressure, there was also increase of endoglin in the blood, and also diastolic blood pressure showed the positive correlation with Pearson correlation of 0.861. In this table, as we can see, there were 19 cases which showed that the patient had a preterm delivery, and in these cases, there was the serum endoglin levels was higher, which was around 16.7 with a standard deviation of 2.81. And in the birth weight, there were 10 cases which delivered low birth weight baby and also showed a serum endoglin level on the higher side, which was 17.1 plus minus standard deviation of 2.84. Coming to the birth outcome, which the patients or the cases which had stillbirth had also a serum endoglin level of a higher level, which was more than 19.3 plus minus 1.2 standard deviation. And in this maternal complication, we had 13 cases which had maternal complication and also showed the increased level of serum endoglin, which showed 18.1 to 1.99 standard deviation. And all these parameters showed a p-value which was significant of 0.000. Coming to the ROC curve, here it showed that the sensitivity of this serum endoglin was around 80% and the specificity around 75%, and the area under the curve was around 80%, which showed that this biomarker could be a good predictor of the occurrence or the severity of preeclampsia. Coming to the discussion, our study demonstrates that the level of serum endoglin is increased in all cases compared to control group. There was a positive correlation between serum endoglin with systolic blood pressure as well as diastolic blood pressure. And these findings are in agreement with the study done by El-Hawari and Sachin R. et al. A little bit about the mechanism of serum endoglin in preeclampsia. It blocks the TGF-beta mediated activated of the endothelial nitric oxide synthase vasodilation, which then leads to the endothelial damage, systemic inflammatory response, which in turn leads to placental hypoxia, ischemia, and increased blood pressure with proteinuria. And the ROC curve analysis, which have been shown earlier, showed that the area under the curve of endoglin is 0.81, And the sensitivity and specificity of serum endoglin is around 80% and 75% respectively, with a cutoff value of 10.5 nanogram per milliliter, recommending its utility as a new biomarker for preeclampsia. There was a study by Geber et al. Also which reported that specificity and sensitivity of serum endoglin for the diagnosis of preeclampsia was 90.1% and 87.5% respectively. In conclusion, the study confirms that the association of serum endoglin with preeclampsia and serum endoglin plays a valuable role together with the blood pressure. Here, serum endoglin in our study can be used as an additional biomarker along with the blood pressure and proteinuria for early diagnosis and detection of preeclampsia and predict its severity as well as improve the outcome. Thank you.
Thank you, Dr. Rachel. My question is, if you're suggesting to use the serum endoglin as a biomarker of preeclampsia,
Yes,
what precautions you will be advising after collecting the serum samples?
Oh, the precautions?
Precautions of handling the serum samples.
Okay. Ma'am, actually the serum can be kept, for this test, we can be kept for around 1 to 2 months. So we can, the main thing is just the serum to be refrigerated, ma'am. The
It's
serum which
refrigerated.
collected should
So
be refrigerated.
how you have refrigerated that sample?
Ma'am, we kept it in the, not in the freezer zone, but in the normal around
4 to 8.
4 to 8 degrees Celsius.
Is it acceptable for the for the serum endoglin? Because otherwise, for long-term storage, you know, we
Ma'am,
usually
yes, we don't usually keep for a long term, but we try to do the test as soon as possible to get a more accurate result, ma'am.
Okay.
Thank you, ma'am.
Rachel,
Yes, sir.
good paper.
Thank
And
you, sir.
how early should we do this test, and how early can it predict the
Sir,
possibility of preeclampsia? At what trimester or at what
Okay,
certain point of time?
So actually, this serum endoglin can be detected at around 12 weeks of gestation. So we can advise the patient if we see any risk factors which she has. We can advise them to take at around this 12 weeks of gestation, and it will help in the early detection of preeclampsia and also improve the treatment and effectiveness of the treatment of preeclampsia and
12
help
weeks.
to decrease the complication.
12 weeks, you said?
Sir?
12 weeks, you
Yes,
said?
sir.
Okay.
12 weeks and above.
Okay, thank you.
Very nice paper, Dr. Rachel.
Thank you, sir.
Do you think this investigation can be routinely, do you think, is it viable clinically to be advised routinely? I mean, can it be put into practice? Just give your opinion.
So actually, it is a little bit on the expensive side. So in our population, it'll be a little bit difficult, but we can do a better test with more sample size to see its effectiveness, which will be more accurate, sir. So after that, I think it can really help to detect it earlier, the preeclampsia, which is a disease which is easily treatable. And if we can detect it earlier, around 12 weeks, so it can help us to treat, and the effectiveness will be more, sir. And the mortality and mortality and morbidity of the cases ahead will be decreased, sir. And assessed. Thank you, sir.
Please collect the marks from the judges meanwhile.
Okay.
So overall, I would like to give a comment from the scientific committee that all the participants perform well, but there needs to be some improvement in the slide preparation. Okay, because some of you have made the slides in paragraph form. Okay, because this will not be the only platform where you will be presenting. Some of you may proceed and present in national and international forum later on in life. So you need to prepare the slide in a better way, not in paragraph form. There should be maximum 5 to 6 bullets per slide, and preferably for each bullet, or at least for each page, give the reference, instead of writing the reference all together in the last page. Okay? Because you should follow what is followed across the globe, so that people will accept you better. Okay? Meanwhile, I'm happy to announce that after several years gap, we are getting response for tempolamine case, Itocha award, because I have been involved, part of the scientific committee for the last 7-8 years of Amamikon. I am one of the longest members in the scientific committee somehow. But we have never got any response for this competition for the last several years. And I'm happy that we got this time. And we'll encourage more people to participate in this competition. We'll be happy if we have more participants. So we'll start for the next
Thank you, Chairpersons. Wonderful presentation to all the postgraduate students. Now we will continue with the next award session, and I request Sir Jitendra and Sir Andy to continue as a chairperson. And this Tampak Lima and the KS Itocha Award is for IMA members who have completed their postgraduate. We have 2 participants in this award session. Before we proceed with the award session and hand over to the chairpersons, I, on behalf of the organizing committee of Amamikon 2020, welcome Dr. Namaram Sukumar Singh Sir, one of the senior member of IMA and one of the most active IMA member. Let us give him a round of applause. Sir, we welcome you. We also welcome Dr. P. Narendra Singh, Senior Consultant, CJ Hospital, Retired Superintendent, Jail Hospital. Sir, welcome. Now we'll continue with the next award session.
Competitor is Dr. Tina Das. Dr. Tina Das, please.
Good morning, respected teachers, the faculties, the judges, and all present here. I'm Dr. Tina Das from Department of Biochemistry, RIMS, and the topic that I'll be presenting today is titled as Serum Level of Procalcitonin in Acute Coronary Syndrome. As we all know that this acute coronary syndrome is a range of condition which is associated with a sudden reduced blood flow to the heart. And it includes unstable angina, ST elevation MI, and non-ST elevation MI. It is one of the leading cause of death, and an estimated 17.9 million deaths do occur every year for this disease. And 10% of the patients that has attended the emergency department with complaint of chest pain were diagnosed with myocardial infarction. This is the timeline which shows the development of different cardiac biomarkers till date for the diagnosis of acute myocardial infarction. And it has been seen that until 1960, it was on the basis of chest pain and the ECG changes that the diagnosis was done. Then later, several markers were developed, such as in 1964, aspartate transaminase, then in 1970, creatinine kinase and LDH. And in 1978, the myoglobin was identified, but it was seen that all these biomarkers, they were not cardiac tissue specific. They were also raised in some other diseases also. So later, in 1980, CKMB and in 1990, troponins were identified. These two are the principal biomarkers that are used till date for the diagnosis of acute coronary syndrome. But the CKMB, it rises 6 hours after the attack, and TROP-I and TROP-T, they rise after 4 hours of the attack, which means that if a patient comes before 4 hours, then the values of these two markers will be normal, and we may lose the patient. We may not identify those patients as acute coronary syndrome, and early management cannot be done. So researchers were always in the lookout for markers which can early diagnose the disease. And one such marker that has been identified is procalcitonin. Now this procalcitonin is an inflammatory marker which we get it from pre-procalcitonin, that is when the amino acid signal from the amino terminal is cleaved, we get procalcitonin. Now something about what is procalcitonin. It is released from the by stimulation of the gene that is calC1, which is present both in the thyroid gland, the parafollicular C cells of the thyroid gland, and the adipocytes. But in normal conditions, serum calcium glucocorticoids, glucagon or gastrin, they stimulate the calci-1 gene, which leads to the production of procalcitonin. But in thyroid gland, in the normal healthy individuals, this procalcitonin, it is cleaved to calcitonin, which is then released into the bloodstream. But if there is any infection or any injury which causes inflammation, then the inflammatory cytokines, they are circulated and they activate the calci-1 gene of the adipocytes, which leads to the production of procalcitonin. But here we see that this procalcitonin is not cleaved to calcitonin, and as a whole, the procalcitonin is released in circulation. So in any case of inflammation, the procalcitonin level is raised. So keeping this in mind, the study was taken up to determine the serum procalcitonin level in the acute coronary syndrome cases and to compare and correlate their values with the diagnostic accuracy of cardiac tropi and creatinine kinase MB, which are the established biomarkers used now. This has been a cross-sectional study done in the Department of Biochemistry in collaboration with Department of Medicine, RIMS, for a period of 2 years. And all individuals or cases who have been diagnosed with acute coronary syndrome, more than 18 years of age, irrespective of sex, caste, and creed, and were willing to participate in the study, were taken as the study population. And individuals who were diagnosed or suffered from the diseases such as fever, burns, and so on were excluded from the study. The biochemistry profile that has been done in the study is serum procalcitonin, serum CKMB, and serum cardiac troponin I. Now coming to the results and observation, this table 1 shows the baseline characteristics of the study population, which includes the age, the gender, the rural, the inhabitants that were from the patient he is from, their occupation, and their comorbidities which they presented to the hospital. The study population mostly presented with chest pain, and the other complaints were like breathlessness, palpitation, sweating, abdominal pain, vomiting, and giddiness. Most of the studies were suffering from ST elevation MI followed by non-ST elevation MI and unstable angina. This table shows the values of serum procalcitonin, serum CKMB, and cardiac troponin I. Now it is seen that the normal range of serum procalcitonin in healthy individual is very less. It should be less than 50 picogram per ml. But in this study, it was seen that the value was raised, and the median value was 405, which is much elevated. The CKMB, the normal range is 5 to 25 units per liter. But in this study population, the values were raised, and the median value was 58 units per liter. Cardiac troponin also, the normal range is 0 to 0.4 nanogram per liter per ml. Whereas in this study, the value was raised, which was 2 nanogram per ml, the median value. This table shows the correlation between the serum procalcitonin and CKMB and tropi, and it was seen that in this study, the serum procalcitonin positively correlated with both these established biomarkers, and it was statistically significant too. This is the ROC curve showing the relation of serum procalcitonin with acute coronary syndrome, and it was seen that a cutoff value of more than 382.50 picogram per ml of serum procalcitonin was recorded with a 73% sensitivity and 53% specificity to predict acute coronary syndrome. Coming to the discussion, in this study, it has been seen that all the cases of acute coronary syndrome had raised serum procalcitonin level, which was in accordance to a study done by Rahmani F. et al. And Kafkas and et al. Now, inflammation and injury is always a part of the acute phase of reactions, which leads to inflammation and leading to the production of procalcitonin, which is closely correlated to the type of systemic inflammation present in the individual. Procalcitonin level has been seen to rise earlier than any other inflammatory markers in response to infection or any other trauma, and it has been seen in study done by Indino P. et al. The increase in serum procalcitonin may be due to the cause that whenever there is any injury or local tissue damage to the myocardium due to ischemia or necrosis, there is release of non-specific cytokines which leads to the increase of procalcitonin in the serum. When cells are damaged due to any reason, disruption of the cell membrane occurs, which releases the internal components, triggering the immune reaction. The increased procalcitonin has also been seen to show the severity of inflammation present in the patients of acute coronary syndrome. The limitations that are there in this study was seen to be like serial measurements of the serum procalcitonin could not be done, and uniformity in time interval between the onset of symptoms and withdrawing of the blood sample for testing could not be maintained, as the time of presentation of the patients to the hospital was very variable. Now I can conclude that multi-biomarker approach is always ideal to diagnose a disease, that it increases the or enhances the diagnostic accuracy and always has a broader clinical application. And this study provides an evidence which favors the clinical value of measuring serum procalcitonin as a diagnostic index for acute coronary syndrome. Thank you.
It's a very good paper, Dr. Tina Das. How do you compare these with CKMB or TROP-I? How do you, because we are using CKMB and TROP-I because they are cardiac specific. But what about procalcitonin?
So in this study, we have, from the patient, we have collected samples for estimating all these samples, all these biomarkers, both procalcitonin, CKMB and TROP-I. CKMB and TROP-I are the established markers, but we wanted to see that whether procalcitonin was also raised in this population. So it was seen that all the patients of the acute myocardial infarction cases that were under the study had raised level of procalcitonin. Normally it is usually in healthy individual less than 50 picogram, and sometimes it's undetected also. But in these cases all were raised.
Tina Das,
Yes, sir.
a very good paper you have presented.
Thank you,
You
sir.
have added one more armamentarium in our basket, diagnosing acute coronary syndrome. What about your opinion of doing alone this procalcitonin will be of any use without the other gold standard tests so far we are using?
So actually, the researchers are doing this study to use procalcitonin as an initial screening tool only, because CKMB and TROP are already established and we use that. But to coming to a conclusion that whether PCT can be used as a single tool or not, I think a larger population study should be done. And this kind of study in Manipur has not been done earlier. So we wanted to see whether it was PCT was raised or not. Since it has been seen that it is raised, so I think a larger population study and then serial time measurement of the PCT level in the same patient if done, I think we can use this PCT as a screening tool, at least for patients who come with family history of ACS or who are hypertensive, obese, have a sedentary lifestyle. In them we can take PCT as a marker to know that whether these patients are prone to develop ACS or not. So I think so it can be done.
Thank you.
In inflammatory instances, it's been known that PCT rises also after 2 to 3 hours.
Pardon,
Okay.
ma'am?
As an inflammatory marker,
Yes.
PCT rises later. It's not that it rises instantly or after 1 hour. It takes time.
It takes time.
Right. So in case of, as a marker of this, has there been any study? Has there been any study that gives the timeline of this PCT interval?
Yes, ma'am, it has been done. There has been done studies done where serial measurement of PCT was done. And
Okay,
it was
so
seen that the severity of inflammation correlated positively with the rise of serum PCT level. And the survivors who have survived the attack, there the level of PCT was a bit low as compared to those who had the attack and were admitted at a later time interval. So time interval, like points were taken into consideration, like when the patient comes to the hospital, when the serum was taken, and and comparison between the other patients who have immediately come to the hospital. So comparative study was also done to see whether there was a rise with the inflammation, severity of inflammation was there or not. And one advantageous point of PCT with the CKMB and TROP-I is that CKMB and TROP-I only rises when the attack has already occurred, and prior to 4 hours, we do not get CKMB and TROP-I level elevated. So we cannot identify whether it is an MI case or not. But PCT, it has a higher value even when inflammation has just started. So this is an advantage of PCT over the other two.
Okay. Thank you.
Thank you, ma'am. Thank you, sir. Thank you.
Last participant from Kausham.
A very good morning, respected teachers, my senior, my colleague, and junior. Today morning I'll be presenting my study on the outcome of meniscal root repair in elderly patient. Root tear is defined as a bony or soft tissue root avulsion injury or radial tear within 1 centimeter of the root attachment. So the most important function of the menisci is to produce an equal load distribution over the knee joint. Weight bearing produce an axial load which compress the meniscus, thus producing a hoop stress. And if the meniscus is torn, this hoop stress is lost. So root tear is equivalent to total meniscectomy because it results in complete loss of hoop stress, causing increased tibiofemoral contact pressure, causing painful bone edema and subchondral insufficiency fracture of the knee, resulting in early degenerative joint disease. So will root repair be beneficial in older patients? In a study by Laprat et al., they concluded that patient less than 50 years has an outcome similar to those of patient more than 50 years. And in older patients, whether to do root repair or partial meniscectomy. In a minimum 5-year follow-up study comparing between root repair and partial meniscectomy, they found out that the rate of conversion to total knee arthroplasty was 35% in partial meniscectomy group, while there is no conversion to total knee arthroplasty in root repair group. So the surgical options that we have are direct fixation using suture anchor and indirect fixation by suture pulled through a transtibial tunnel. There are 2 types of indirect fixation. Number 1 is single tunnel and number 2 is double tunnel. In a study by Lapret comparing the biomechanical comparison between single and double tunnel, they concluded that both technique has a similar biomechanical properties. Thus, our aim is to evaluate the outcome of root repair in elderly patient. It is a prospective clinical study. Duration is 1 year, and our inclusion criteria are elderly patient more than 60 years with osteoarthritic grade 1 and grade 2. And age less than 60 years, osteoarthritic grade 3, 4, and meniscal repair in a region other than the root with various malalignment greater than 3 degree are excluded from our study. Then we evaluate the outcome using IKDC and Lizom score, and radiologically we evaluate using Kim-Metal criteria and cartilage degeneration using ICRS score. This is a slide showing Kim-Metal criteria of root healing. These are the instruments that we use for our surgery. First, diagnostic arthroscopy is done to confirm the diagnosis. This is a arthroscopic image showing medial meniscus posterior root tear. And this is the final picture after the posterior medial meniscus root is being repaired. And the fiber wire is tied over a suture post. First patient, a 60-year-old female patient complaining of pain in the left knee, cannot recall an inciting event of injury. Her X-ray saw grade 2 osteoarthritis. In her MRI saw extruded meniscus on coronal view, and in axial view, it saw high signal intensity. And in sagittal view, it saw ghost sign. These are the signs indicating that the patient is having a posterior meniscus root tear. And at 18-month follow-up, the patient X-ray is normal, and her MRI shows complete healing of the meniscus. And the extruded meniscus is decreased. Case 2. A 64-year-old female patient complaining of pain in the left knee cannot recall an inciting event of injury. Her X-ray saw grade 1 osteoarthritis, and her MRI saw ghost sign on sagittal view and hyperintense signal over the posterior meniscus and extruded meniscus on coronal view. These are the signs of root tear. And her follow-up at 18 months, her X-ray looks normal, and her MRI saw incomplete healing of the meniscus. In spite of the incomplete healing, the extruded meniscus is reduced. The patient is advised non-weight bearing for 6 weeks, and from post-op day 1, the patient is allowed 0 to 90 degree range of movement, and after 2 weeks, as per tolerate of the patient is advised to avoid deep leg pressure or squatting for at least 4 months post-operative. Of the 10 patients, 8 are female, 2 are male. Mean age is 64. Duration of follow-up ranges from 18 to 24 months with a mean BMI of 26.14. This is a table showing demographic data of the patient. All the patient had a posterior medial meniscus root tear. The IKDC score preoperatively is 31.9 and at final follow-up it is 74.1. The difference is statistically significant. And the LISOM score preoperatively 46.1 and at final follow-up is 79.5 and the difference is statistically significant. And based on key metal criteria, only 1 patient saw complete healing of the meniscus, while 9 patients saw incomplete healing. And the extrusion of the meniscus decreased from 4.4 preoperatively to 3.3 postoperatively, and the difference is statistically significant. And then the cartilage degeneration based on ICRS grading, only 1 patient saw progress from grade 1 into grade 2 osteoarthritis. The limitation of the studies, the clinical cases are relatively few. Duration and follow-up of studies sought to evaluate the progression of osteoarthritis after surgery. Thus, from this, we concluded that meniscus root repair in elderly patients result in significant improvement of function, symptom of pain, and activity level in spite of incomplete healing on MRI. Thus, in this short-term follow-up, we concluded that healing status on MRI is found to be unrelated with the clinical symptoms of the patient. Thank you.
Awesome.
Awesome.
Very good picture, especially your slide presentations. What are the other options? You might have mentioned, but just tell us what are the other options and what is the advantage of this approach?
Sir, the other option that we have is whether to undergo partial meniscectomy or total meniscectomy. But the thing is that if we go partial meniscectomy and total meniscectomy, the hoop stress of the knee joint will be lost, resulting in early degenerative joint disease. But if we repair, the hoop stress is retained, which maintain the biomechanics of the knee joint.
Okay, that is the advantage.
Yes, sir.
Okay. So you need to do in more cases so that it can be an established norm to approach in this practice, no? Surgical approach.
Yes, sir.
Thank you.
Before the arthroscopic era, what would you have done if you find a ACS here?
Sir?
See, the management you have told are all arthroscopic.
Yes, sir.
If there was no arthroscopy, what will you do?
So if there is no arthroscopic, we can go for intra-articular injection of the steroid with continued physiotherapy. And at last, we can go for knee replacement, sir.
Thank you, sir. We have come to the end of the award session. I think this will encourage more participants in next year, because as I'm telling again, we never had this competition of Kampalama and KH Itocha for the last many years. And because this will serve as a baseline platform. Thank you.
Thank you, chairpersons. Wonderful presentation from all the competitors. We'll be waiting for the result. This comes to the end of our award session. Thank you, judges. Oh, madam. Madam, ki question wali hai?
I just would like to share a few words, especially with the presenters. Okay. Thank you to all the presenters. You know, it's been enlightening for us too. We are always in the learning process, and we have learned from you too. And the materials and your studies, for all of you, it's been good, I should say. But after all, this is competition. There has to be one winner. But it is the spirit. We really appreciate your spirit. It is the spirit that counts for you. For your future, what I would like to suggest is that, you know, whenever you are presenting, we tend to be attracted to the laptop. We tend to be as close as so that we don't miss a word or a sentence or something. So be confident. Try to step away a little bit from the laptop. And maintaining the eye contact is very important. It's very, very important, I should say. Be confident to have an eye contact with the audience, with the judges, with the chairperson, and your friends. Select someone who will be, encouraging you with their notes or something. Maybe your friend. Okay, that will give you the confidence to be there. And, finally, after all, when you are presenting a paper, the stage is there for you. Step away and with the right attitude, interact. Okay, but attitude is very important. So thank you all.
Thank you, Madam, for your kind and enlightening words. This comes to the end of today's award session. Sir, please. Now we'll have a felicitation of all the 3 judges who have come early morning for us. I would like to request Sir Jugendro, Dr. S. Jugendro, Vice President, IMA Manipur State Branch, to kindly felicitate all the 3 judges. Sir, I because I'm felicitate. First, I would like to call upon Dr. Ranjana, Madam, please. Thank you, Madam, for coming early morning. And we have started our award session on time. Photo di, photo namo camera ay gisit camera ani le nam drem pho jet. Madam Wali, solo ne ay na song thera nam gudro. Namiko. Oh, okay. Next, I would like to call upon Dr. Lennon, sir, please. Thank you for coming, sir. Thank you, sir. And lastly, Dr. Sanjeev Nepram, sir, please. Sir has come after cycling, I think, sir. Thank you, sir. Thank you, sir. Now we will felicitate, sir, please stay, sir. We will felicitate our chairperson, Sir Dr. N. Jitendra Singh, sir, please. And Dr. Salam Ranbir Singh. Chairman of the scientific committee, without whom we will not be able to conduct the scientific program today. Thank you, sir. Thank you very much.
One announcement for the competitors. The winners will be announced just before the general body meeting, because we are having other competitions going on side by side, and we will be taking some time in telling your marks. So please wait till then. We'll announce the result and we'll give the prizes straight away just before our general body meeting. Thank you.
Okay. So next, the next program is Mixed Bag. And here we have 2 renowned speakers. And to conduct this program, I would like to call upon the chairpersons of this session. Dr. P. Narendra, Senior Consultant Physician, CJ Hospital. And Dr. T. Gambhir Singh, Retired Professor and the HOD, Department of Community Medicine, RIMS. Sir, please. pen drive. 15 minutes is the allotted time for this session.
Good morning, everybody. Shall we start now? Okay. So for the next session, the first speaker is Dr. A. Barindra Sharma, Department of Transfusion Medicine, RIMS. So he'll be speaking on the topic rational blood transfusion. So Dr. Barindra, please.
Good morning to you all. My topic is rational use of blood and blood components. Actually, this is a continuing program under National Health Mission and National Blood Policy of 2007. We have been continuing for the last 5 years in our department and the hospital. So why we should encourage rational or judicious use of blood? This is more important for the blood user departments particularly, and more so relevant in our state because the voluntary donation is low as compared to other states. So we need to conserve and we need to rationalize its use. So blood transfusion, it may be life-saving in some instances, but it also carries the risk. So it may result in acute or delayed complications, and not only that, the blood-borne diseases. There is always a risk for every transfusion of TTI, transfusion-transmitted infections like HIV, hepatitis B, hepatitis C, syphilis, and malaria. Because the screening test, what we are employing, it cannot nullify the window period. Even with the best technologies we have, the window period may be shortened, but it cannot be nullified. So there is always some risk. And please think, blood transfusion is like a tissue transplant or organ transplant. And blood, a scarce resource, as we know, there is no substitute, no equal. It is not like a drug which can be bought from a pharmacy. It is not a consumable which can be, say, bought from the market. It has to be from a human being. And unnecessary transfusion may cause shortage for patients in real need. So reduction in unnecessary transfusion is to be considered always. So before any transfusion, we always please see the risks and the benefit. So benefit, it can increase hemoglobin, or it can stabilize the hemodynamic circulation, or bleeding in bleeding episodes, it may be beneficial. But always the risks of TTI, blood-borne infections, then HTI, hemolytic transfusion reaction, then lung injury, transfusion-related lung injury, and transfusion-associated graft versus host disease. So please see these risks and benefit. The benefits should always outweigh the risks before considering for any transfusion. So how can we be judicious? We should always think of simple alternatives to blood transfusion. And the use of blood components, it is also one of the major recommendations for rationalizing blood transfusion. And the whole blood transfusion, it is an obsolete. So it is always a wastage nowadays. And the avoidance of single blood unit transfusion. Why? Say one blood transfusion or one whole blood or PET RBC can increase only 1 gram, maximum 1 gram of hemoglobin. So for 1 gram of hemoglobin, why should we waste one whole blood or a PET RBC? So single unit transfusion, please avoid if it is not absolutely indicated. And always try to assess the underlying cause of anemia, say low hemoglobin. Components are depleting. And good anesthetic and surgical management is also one of the measures. And the benefits should always outweigh the risks. So this is the concept of component therapy. Give only what is necessary. Say red cells we can give when there is low oxygen carrying capacity. Platelets in thrombocytopenia, fresh frozen plasma in multiple coagulation factor deficiencies, and a cryoprecipitate in hemophilia. The reason for transfusion should always be recorded clearly, even in the requisition form or in the case sheet. Hemoglobin value should not be the sole deciding factor, because there can be error. Always clinical assessment is more important than simple level of hemoglobin. Blood transfusion, it is just one part of the management of the patient. And before any transfusion, ask yourself, if this blood was for myself or my son or my daughter, would I accept this transfusion? So please bear this in mind because of the risks it carries. So the goals, this is continuing the component therapy, the benefits. Say right blood in the right dose at the right time for right reasons and the right person. Don'ts. Please do not transfuse blood for volume expansion as a hematinic or as a nutritional support or to enhance wound healing, to improve general well-being. Say before any discharge, just please avoid. Say please discharge the patient after one blood transfusion. This is unnecessary, please don't do. And I am coming to the whole blood versus the blood component. Use of component can maximize the blood resource. So whole blood is meant for only one patient. If we separate into components, it can benefit 4 patients at the same time. Say PET RBC for thalassemia or symptomatic anemia, platelet for thrombocytopenia, fresh frozen plasma for liver disease, cryoprecipitate in hemophilia. So 1 patient versus 4 patients at the same time. So this is the different concept of component therapy. See whole blood versus PET RBC. The same PET RBC, in whole blood there was an old concept that whole blood has everything in it. It is totally wrong. Say you might think that whole blood has everything, say viable coagulation factors, platelets, but it is never so. After storage, even for 24 hours, there will be no viable platelets and no viable coagulation factors. Means it will be at the lowest level. Nearly 80% to 90% will be lost in storage for 24 hours. But we are going to store for 35 days. So the concept of whole blood is it has everything, it is totally wrong. Please avoid. See, even use of whole blood is more dangerous in this, please see in this chart. See plasma citrate, plasma potassium, then risks of TTI, allergic reaction, then hemolytic, non-hemolytic transfusion reaction, and wastage of component. All will go with the whole blood. So by component we get the concentrated dose of the required component. Then it can avoid circulatory overload and minimize reactions. Because most of the reactions in blood transfusion are due to the plasma. So if we give whole blood, more plasma is there. So even all the risks are associated with plasma. And why the whole blood cannot be used? Because of these storage conditions. PET RBC has to be stored at 2 to 6 degrees. So platelet at 20 to 24. And FAP and cryo at minus 30 degrees. So whole blood cannot have this. At 2 to 6 degrees, we cannot have platelet and we cannot have FAP because of these considerations. So whole blood is like a shotgun approach, something of everything. Whereas component therapy is the targeted therapy. We can also say as a targeted therapy. So this is how we separate from one whole blood back. And this is possible because of the plastic bags available, multi-bags. Previously it was mostly on the glass bottles. It was impossible. But because of the plastic bags, but it is not a simple plastic. There is always some, say, aeration, respiration with all the blood components. And these are some of the parameters what we employ, and this is at the national level. Please do not transfuse if hemoglobin is more than 10 gram per cent in non-bleeding patient. If bleeding is there, then we can consider. transfusion is indicated if hemoglobin is below 7 gram per cent. It is not absolute. If symptoms are there, and transfuse blood when hemoglobin is 7 to 10 in symptomatic or cardiorespiratory insufficiency. And transfusion is absolutely indicated if hemoglobin is below 5. Again, I will emphasize, please do not strictly follow on the level of hemoglobin. There can be errors. The method we employ in testing hemoglobin, because the most accurate method is actually SIMET, which many do not employ. So always clinical assessment has to be taken into account, not simply the hemoglobin. Yeah, this I have already mentioned. The component preparation is possible because of this. Multiple refrigerator centrifuge what we have, then different specific gravities of all the blood components, so separation is possible. So clinical requirement of a patient determines which blood components should be transfused. So it can be by apheresis, by our traditional method also, and the apheresis, cell separator also we can get all the components. These are some of the major components in use in the hospitals. Say red cell or PEG cell, PEG RBC, platelet concentrate, fresh frozen plasma, and a cryoprecipitate. But there can be other products from the plasma that is done in the fractionation centers. Yes, whole blood has just limited, these are some of the limited indications, say in active bleeding or intrauterine transfusion or exchange transfusion in neonates. So these are few indications, but here also we can use PEG RBC with normal saline on one side. Even in a bleeding patient, these are the steps. This is our domain. From one whole blood, how we get all these components. This is what we are doing. Light centrifugation, then heavy centrifugation, then all the products. PEG RBC, platelets, fresh frozen plasma. And a cryoprecipitate has to be prepared from the fresh frozen plasma. It is one byproduct. So indications of red cell concentrates, as I have already mentioned some. So it is, the major indication is prevention or treatment of symptoms of tissue hypoxia by increasing the oxygen carrying capacity. So requirement is based on clinical status rather than the hemoglobin or hematocrit values. So other indications, symptomatic chronic anemia, normovolumic, if the drug therapy is not effective. Always please start with the alternatives. Please do not think transfusion first. This is a scarce resource. So please try with the medication. If not effective, please think of transfusion. And the active bleeding, unresponsive to crystalloid or colloids. And the pre-operative anemia, less than 9 gram with impending major blood loss. Anemia due to renal or hemodialysis refractory to erythropoietin, thalassemia, sickle cell. So all the blood, these components can be liquo-reduced. This has many advantages with the use of liquor filter. So fresh frozen plasma, please don't misuse it. It has to be used with when the prothrombin time or partial thromboplastin time is more than 1.5 times of the normal, or INR is more than 1.5. Always before considering FFP, please do either this prothrombin time or partial thromboplastin time. Otherwise, it is of no use.
Professor Benga, please try to shorten.
Okay. So clinical indications, major coagulation deficiencies, liver disease. Cryoprecipitate, it is mostly for hemophilia. Nowadays it is not used because of the availability of the factors. And in platelet, I just want to emphasize one point. It is many times, say ITPs, the platelets are requisition, but it is not. If there is no life-threatening complication expected, we should not consider platelet transfusion. And fresh blood is always a misconception. It is when components are available, it has no use, it has no meaning. So to conclude, blood transfusion is a life-saving intervention, but not without risks. Clinical benefit should always outweigh the risks. Component therapy has to be considered. Justify the need for transfusion and please document it. Monitor transfusion appropriately and let's avoid unnecessary transfusion. Thank you.
Thank you, Barindra, for the detailed presentation. We have learned many things from this. Thank you very much.
Yes.
Any questions and comments? If none is there, thank you, Barindra.
Yes, thank you.
Our next speaker is Dr. Nitya sir from Caesar Hospital, consultant. The topic is avoiding nerve injuries in thyroidectomy. Dr. Nitya sir.
Egypto.
Master, sir. Good morning, my dear teachers, my dear fellow, my seniors. Today I'm going to, it gives me immense pleasure to give a talk on the topic of avoiding nerve injury in thyroidectomy. And why thyroidectomy is so fearful for many is because of the nerve injuries and the consequences that it gives. Thyroidectomy is like dealing with a hostage crisis. You have a target which has, which is holding the hostage, and the target is the thyroid that we have to remove, and the hostage is the rectal laryngeal or the superior laryngeal nerve, or even the parathyroid also. So, as a sniper or a person who is going to take out the target, we need to know very carefully the anatomical differentiation, identification, and preservation of the nerves. Before we go to my talk, let me show you how a vocal cord is. Excuse me. normal vocal cord, it opens during our respiration, and then it closes during speech, during swallowing, and during coughing. So this is how our normal vocal cord is. It dilates on both the sides. Let me have that. Now, if one side of the recurrent nerve is injured, then what happens? One side of the vocal cord is paralyzed, but the other side compensates for the loss of one side. So there is some change in voice, some change in some little bit difficulty in speech and swallowing and respiration, but not that much. Now when we try to see bilateral paralysis, now see, nothing is in the pyramidal position, it doesn't open, and so the difficulty is so much for the patient and it's so much distressing that it becomes very difficult for the patient to resume normal duties. And the breathing is like, if I have to imitate it, like that. So just imagine how much difficulty it may have, or it may cause to the, the normal part of the future life. Now there are certain risk factors. That is the most common being the lack of recurrent laryngeal nerve identification during surgery, and it is so important to identify it and to preserve it positively. And especially when bilateral surgery are done, or surgery for the cancer, or surgery for associated lymph node dissection or neck dissection was there, surgery for Graves' disease or thyroiditis where the blood supply is much higher. In case of revision surgery, because of the adhesions in surgery with substernal goiter, because of the expansion and because of the distortion of the anatomy. So, and in cases where there is longer operating time or a greater blood loss, because while trying to control the bleeding, we may inadvertently injure or cauterize the recurrent laryngeal nerve, and that causes all this problem. So in order to identify and to preserve the recurrent laryngeal nerve, we need to know certain points, and that is, let's start from the beginning of embryology. It's a brief, the thyroid gland starts appearing from the foramen cecum as an invagination, and then it goes down, and then it reaches the level of the cricoid at 7 weeks, and by 12th week, the thyroid hormone starts secreting. But now most important is recurrent laryngeal nerve. Now recurrent laryngeal nerve develops from the 6th bronchial arch, and it turns and it gets, under the 5th and 6th bronchial arches, the bronchial arches, the aortic arches, and then these two arches, it disappears during our development, intrauterine development. These two arches. So when these two arches disappears, then the recurrent laryngeal nerve starts get entangled just under the subclavian artery on the right side and the aortic arches on the left side. Now why this is so important? Because the next is, suppose if there is a case of any anomalies where the subclavian artery, instead of coming up from here, it's going from this side, and that's called arterial luxuria. In such condition, there is nothing to entangle the vocal cord, the recurrent laryngeal nerve. In such cases, instead of going down and then coming up, the recurrent laryngeal nerve just stays above. And it is a rare, of course, 0.21 to 1.6% only, but still the chances of injuring is very, very high if you haven't anticipated it. Now, the superior laryngeal nerve has got two branches. One is internal and one is the external branches. The external branches, it supplies the cricothyroid. So the cricothyroid, the function is to tense the vocal cord, so it gives high pitch to the voice. And it is very, very important for certain people like vocational or professional voice users. You must have heard about Emilia. And this superior laryngeal nerve, there are many divisions or classifications that's given, but the most common and the easiest is the Cernia classification, where superior laryngeal nerve is classified according to the level of entry in the thyroid, in the cricothyroid. If it is above, then it is called type A, above 1 centimeter. If it is within 1 centimeter, that is called type 2A. And if it goes beyond the level of the superior limit of the superior lobe, then it is type type 2B, sorry. Now, as I've seen earlier, recurrent laryngeal nerve is just like a hostage. So, why it is so important is we need to neutralize the target, but we need to preserve the hostage. Otherwise, there's no point in doing so. So, the most important being it supplies all the intrinsic muscles of the larynx, and it also gives sensation to the larynx below the vocal cord or cardiac plexus, or even to the esophagus and to the trachea as well. So there are variations of recurrent laryngeal nerve. It can be, this is inferior thyroid artery, the recurrent laryngeal nerve is like this. It can be, behind, or it can be in front, or it can be in between the branches of the inferior thyroid artery, or it may even be within the Barrett's ligament. So while we are trying to dissect the recurrent laryngeal nerve, we should also know that around 30 to 78% of the recurrent laryngeal nerve has got branches. See, the anterior branch and the posterior branch. It branches before it enters into the larynx. So what happens is, if we are doing the surgery and then we are dissecting it, and then we are thinking like, okay, we have seen one branch, but we thought like this is the recurrent laryngeal nerve, and then we sacrifice every other branch, then it may still give paralysis. And also, the position of the recurrent laryngeal nerve is quite variable. It can be over the esophagus, it can be over the trachea, it can be in the tracheoesophageal groove. Why this is very important is, if we know the anatomy, then the chances of injuring the recurrent laryngeal nerve is very, very less. Some surgical triangles are being described, and the commonest being the Bierce triangle, where the base is formed by the carotid artery, the superior boundary is by the inferior thyroid artery, and the medial boundary is by the recurrent laryngeal nerve. Or there is called Simon's triangle also, but a very important triangle is this Loris triangle, where the carotid artery is one part, the inferior thyroid is another part, and the trachea is another part. So in between this triangle, you will always find the recurrent laryngeal nerve, if it is recurrent and not non-recurrent. If we don't find it in this triangle, start thinking about non-recurrent laryngeal nerve. And this is the area of concern where all the blood vessels and the nerves get there, and then it is a tight compartment, and then if you miss some fine dissection, then bleeding occurs, then it's a whole mess. So we need to be very careful. And then superior laryngeal nerve is, we find in the Jaws triangle, and it is bounded by medially by the midline, laterally by the superior thyroid lobe and the thyroid arteries, vessels. And then this is the attachment of the strap muscles. In between this, you will always find the external branch of the superior laryngeal nerve. Now there is another called cricothyroid space of Reeves. It's an avascular space between the cricothyroid muscle and your superior lobe of the thyroid gland. Again, here it's the superior part of the recurrent laryngeal nerve is possible. Now, after knowing the anatomy, there are certain surgical approaches. It has got its own advantages, disadvantages, and benefits. One of the common thing is to do a capsular dissection, and this capsular dissection is between the true thyroid capsule and between the visceral fascia. And this visceral fascia and thyroid capsule, if we can preserve the plane of dissection here, the recurrent laryngeal nerve is always at the back. It's at the back. But this is a very tight space. So what happens is, if suppose the recurrent laryngeal nerve is, it has got a branches, and then if you are doing the capsular dissection like this, you may cut upon the branches of the recurrent, and then you can give paralysis, vocal cord paralysis. If your plane of dissection is little bit posterior, then the whole recurrent is gone. You may even not know that it's already transected. So we have to have a very clear anatomical point, because see here, the recurrent laryngeal nerve is almost attaching to the thyroid gland, and to separate from that thyroid gland is difficult approach. The another thing is the extracapsular dissection. In this extracapsular dissection, we dissect, positively identifying and preserve the recurrent and the external branch and even the parathyroid. Let me show a small clip. See, this is the great vessel, the carotid. This is the trachea, and this is the inferior thyroid artery. So the recurrent laryngeal nerve is always in this triangle. And this space is an avascular, relatively avascular, loose areolar space. So identification of the recurrent in this area is quite easy, as well as below the nerve is always in a single trunk. So there is hardly any branches. The chances of having a branches in there is very low. So there is another called lateral backdoor approach, where we go from the lateral side just adjacent to the sternocleidomastoid muscle, and then proceed as the capsular dissection. The newer thing is we ENTs, we are very much adapted to using microscope for all our ear surgeries and laryngeal surgeries. So in these cases, if during the thyroidectomy if we use microscopes, see the excellent demonstration. This is inferior thyroid artery. This is the our carotid. This clip I have already shown, and the recurrent is there. Let me show the other one. And see this view we cannot get it with naked eye. The inferior thyroid artery, see the branches, small branches going there, crossing the recurrent laryngeal nerve and then going to the parathyroid. If we follow, the way to identify the parathyroid is simplest when you identify the blood supply of the parathyroid. If we follow again superiorly, see going to the parathyroid, the superior parathyroid. This type of view is unparalleled, magnified, clear, and it cannot be possible with our naked eye. It has to be microscope. We need to use a microscope. And there are different ways to injure nerves. I've said some, but see, anatomical variation, positive identification, avoid unjudicious use of monopolar cautery, use bipolar cautery judiciously, avoid too much traction, avoid clamping of the nerves, use microscope, and if it is injured, then there are ways to deal with it as well. But the biggest problem we are facing is, see, only 95% or more than 95% of the surgeons don't use this anatomical location to dissect the nerve or to identify the nerve. Very few people use it. So the mantra to save the nerve is, we should know that the cause is highly variant. Injuring the incidence of nerve paralysis is 3 to 4 times greater in cases where the recurrent was not localized during the surgery. So always try to seek, expose, identify, and preserve it instead of just avoiding. Extracapsular approach with nerve identification is the method of choice. And the take-home message is, if you have to enter a lion's den, first know where the lion is, and then take steps to avoid certain consequences. Thank you so much. Sir. Thank you so much.
Questions and query from the staff, from the attendants.
Dr. Professor, very nice presentation.
Sir, thank you so much.
By the by, do you have do you find any study of nerve injury in thyroidectomy?
So there are lots of studies worldwide, and they give an incidence of around 3 to 14 or 16% of nerve injuries happen in thyroidectomy, and that is most common when the recurrent laryngeal nerve is not identified intraoperatively.
If it's identified intraoperatively, it is 3 or 4 times lesser, the chance of injuring. And injuring not only means the cutting of the nerve, but it also means the traction injuries, the axonomesis, the neuromesis and all. So some partial temporary paralysis may also be there. But however, in 3 to 4 months' time, it always recovers most of the time, maximum
so
time.
I mean, here in Manipur also, you have
in Manipur, actually, sir, the thyroid surgeons are less again, and I haven't done any study till now regarding this. We just follow the standard protocol of identifying the nerve in each and every cases, in all cases. And if I have to say, sir, I've been involved in more than 500 thyroidectomies, if I have to count in the place where I was trained, and I haven't seen a single permanent paralysis till now, following this approach.
Okay, in that case, some form of any retrospective study or prospective study that will be very helpful in future also.
Exactly, sir. Yes.
Thank you.
We will try to do it in future.
Dr. Nitiso, that was excellent presentation. Dr. Nitiso is my junior during my MBBS time, so the way you presented is so clear, and video and all those things is very clear to me. I have some doubt. Some of the patient or we advise for thyroidectomy, and ultimately they come with hypopara.
Yes.
So what is the prevalence of hypopara after thyroidectomy, or is there any, you have shown the parathyroid inferior superior, so it was a bit easy to look at what you have shown. But sometimes all the parathyroid is gone and patient ultimately land in hypopara. So in your experience, which one is more difficult to identify?
Actually, the parathyroid is more difficult to identify because it has got very various locations. It can range from the upper neck to the thymus. The superior is quite constant. Means it gets occupied in the small space, but the inferior is very variable. So the injuring the parathyroid is much more difficult. And then recurrent angina, you identify the nerve and you preserve it. But the parathyroid, even if you identify the parathyroid, but if you injure the vasculature, there's no point in putting that parathyroid. And good thing is recurrent, there are 2, parathyroid, there are 4. So in hemithyroidectomy, we usually don't come across these things. Of course, there may be transient hypocalcemia there, but in course of time, it improves.
Okay. Another one is, this is just for my knowledge only. Another one is, patient after thyroidectomy, they presented with, a transient palsy of the vocal nerve. So how long we can wait? Because during my stay there also, many patients after the thyroidectomy, they come with hoarseness of voice, and we do IL, and we found that there is some paralysis of the vocal. So suddenly used to tell us, no, you just wait for some time. So how long we can wait?
Sir, actually we need to assess the patient at the earliest. If it's bilateral paralysis and the vocal cord is in the paramedian or the median position, then if it's in the median position, it could be life-threatening. Okay. If it's in the paramedian position, she may continue it, but then it's very difficult to continue. So we should give our option at the earliest, because the thyroid above is there. If what we are going to deal with that patient is inside the larynx, so we can do that one at the earliest. So the severity of the problem or the severity of the dyspnea or the difficulty in breathing, this is the main criteria how fast we can or how fast we have to deal with the situation.
Dr. Nitiso, very good presentation, very nice. Thank you for. My question is, when we usually operate a cervical spine surgery, we go anteriorly, left-sided or right-sided. So usually I prefer, or book says left-sided is preferable because the course of the left recurrent laryngeal nerve are straight. In the right side, I have never done on the right side because it is tortuous or the courses are not straight. So how far it is true? If on the right side?
It is true. The main reason is the aorta is towards the midline, near to the midline. So when the recurrent laryngeal nerve process and then entangles and then comes up, it is near to the tracheoesophageal group in a much midline position. Not exactly midline, but I could say nearer to the midline. But subclavian is again going laterally. So when it curves under the subclavian, it goes laterally and then it comes near. So if we identify these two, if we know these two, one is in the left side is towards the midline, the right side is towards lateral side. So we need to know this anatomical position, and the more lateral means the more dangerous for you.
Thank you, Dr. Lisa.
So if there's no any more comments or questions, then we close the session.
Sir, thank you so much, sir.
Thank you all the speakers. Now we will felicitate the speakers. I would like to request our chairperson to kindly felicitate our speakers for the mixed bag session. Sir, please. Sir Narendra, kindly felicitate Sir Narendra, sir. Sir Narendra ji. Okay, Dr. Nitya sir first, please. Sir Narendra Damta Thibio. Sir Narendra Thiro. Sakra. Sir Sakra, sir, cannot be below, sir. Sir. Thank you, sir. Now we have a felicitation of our chairperson. Thank you, sir, for coming out of your busy schedule. I would like to request, sir, Professor Wan, sir, so kindly felicitate our senior chairpersons. Thank you, sir. Sir, Wali, sir. Thank you, sir. Thank you very much. And thank you to all the audience who have stayed here and listened to all the program. We have a jam-packed hall. Now we have a last session in this main hall. And this is going to be one of the very exciting sessions. We have 4 renowned speakers. And we have as a chairperson for this invited talk, we have Professor O. Guneswar, Department of Orthopedics, Head of the Department Jennings, and Professor Thorbe Henberg, Head of the Department Anesthesiology, Jennings. Sir, kindly come on the stage and chair the session for today's last invited paper. Sir, and I would like to request, Sir, Sir Dr. S. Manikanta, psychiatrist and ex-NHM director, sir, please. Please, sir, I'm really sorry, I should have called your name first. Thank you, sir.
Good morning, everybody, and we are running behind the schedule, and without wasting of your time, we would like to start the session. And this is the last session of the in the pre-lunch session. So we have 4 speakers, and each speaker will have 10 minutes time. And now I would like to invite the first speaker, that is Dr. Dr. N. Saran, cardiac anesthesiology, Jennings. I invite Dr. Saran to start the presentation.
Very good morning to everyone. Today I'll be presenting on the anesthetic challenges in TAVI or TAVR. TAVR is a minimally invasive procedure where a new valve is inserted without removing the old damaged valve. It is an immersion technique with high-risk for the high-risk patient with aortic stenosis with a predicted post-TAVR survival period of 12 months. Aortic valve stenosis is the most common debilitating valve heart disease in adults. Surgical aortic valve replacement is the treatment of choice for the vast majority of patients. The rationale behind the TAVR is it minimizes the overall surgical trauma by avoiding sternotomy and aortotomy, avoiding adverse effect of cardiopulmonary bypass, implanting the prosthesis on the beating heart, avoiding cardiac arrest in order to improve post-operative patient outcome. In a study conducted by partner at trial in 2012, TAVI was at least as good as surgical aortic valve replacement for the high-risk patient, possibly better, and should be standard of care for the inoperable patients. In inclusion criteria, severely calcified aortic valve stenosis with a gradient of more than 40 millimeter mercury, high risk for conventional AVR, and patient is symptomatic. And it is absolutely contraindicated in a place where there is no heart team, and there is no and clinically, if the life expectancy is less than 1 year, anatomically, if the size of the aortic annulus is less than 17, and there is a thrombus in the left ventricle. For the risk assessment, it can be assessed with the help of the Euro score and the STS, predicted mortality rate. There are mainly two approaches are there. One is retrograde and anterograde. The most common one is the transfemoral approach in the retrograde. Before the procedure, cardiac catheterization lab is ideally done in a hybrid operation theater, and it is vital to communicate a plan of management for unexpected events. Any limitation in resuscitation must be well discussed and documented in advance. Heart team is a prerequisite. Conversion to emergency cardiac surgery if a complication occurs that cannot be managed conservatively. In the procedure, initially a pacing wire is placed in the right femoral vein, and from the right femoral artery the guide wire is passed to the aortic valve, and from there the valve is positioned, and then it is balloon inflated and a valve is placed. These are some of the valves, and this was my valve from the Meridian Life Science was used when we did first TAVR over here. The hemodynamic alterations during the procedures were induced because of the induced aortic regurgitation to ensure the positioning of the prosthesis, and positioning and deployment during there is a rapid ventricular pacing at a rate of 180 to 120 beats per minute for 5 to 10 seconds to reduce the cardiac output to enable stable positioning and prevention of myocardial injury. The role of transesophageal echocardiography and fluoroscopy and angiography are: in transesophageal echocardiography, the pre-procedural roles is severity of the AS, aortic valve system, aortic annular size, the distance between the aortic annulus and the coronary ostia is very important. It should be more than 11 millimeter. The diameter of the aorta is very important. It should not be more than 45 millimeter. Intraoperatively, we can assess the valve implantation, the pressure gradient, and after the procedure we can recheck again the pressure gradient. Regarding fluoroscopy, we can assess iliofemoral vessels and aortic and subclavian before the procedure, and we can reconfirm it during the procedure also, and we can position the TAVR especially with the help of fluoroscopy and in a very poor calcified aorta. Post-operatively, we can confirm the placement of the valve, and we can do angiography of the coronary artery to avoid injury to the coronary vessels. The role of anesthesiology in the tower are continual medical assessment and monitoring of the patient, adequate pain relief, relief from anxiety from new environment, control of hemodynamic stability, provide calm and immobile patient to the surgeon, intraoperative TE assessment of the patient, adequate post-operative pain management. The challenges which we observe in this kind of patients are, we are away from the main operation theater, and there is a limited space, very congested. So whether we have to think of, we should go for general anesthesia or local anesthesia with monitored anesthesia care. Monitored anesthesia care is to provide sedation. Over and above the sedation, we should be able to convert it to GA if necessary, and intervene or rescue an airway, relieve pain, manage side effect of anesthetic agents. But still now, according to the recent study, GA is still the mainstay in management of patient undergoing TAVR. In some of the studies conducted comparing general anesthesia and the local anesthesia, they found that the outcome was not much difference in between these two groups. And in some of the studies, they have concluded that there was a lower of 30-day mortality in the monitored anesthesia care patients compared with the general anesthesia, and there was a shorter ICU stay and hospital stay. And I have used dexmedetomidine in this patient. So in a comparison conducted in Korea, they found that successful TAVI can be performed with the dexmedetomidine in close monitoring appropriate during titration, fluoroscopy guidance with or without intra-procedural TE monitoring. The advantage of monitored anesthesia care are, over and above that, the patient's ability to maintain a normal reflexes is very important, and shorter hospital stay. The risks of the monitored anesthesia care are potential for oversedation and hypercapnia, less monitoring information, possible patient movement or discomfort, symptomatic if hemodynamically unstable, then conversion to GA. The advantage of general anesthesia is patient not aware of the procedure or the airway is secured, avoiding emergency airway intervention in case of unfavorable hemodynamic situation. The use of TE is of particular importance in diagnosis and management intraoperatively. The disadvantage of GA are it takes time to establish side effect of GA and physiological consequences of positive pressure ventilation. The critical stages in this time are putting lines in the anxious aortic stenosis patient, then to achieve the anesthetic goal for aortic stenosis and induce AR before deployment of the valve, rapid ventricular pacing, bleeding from the side. These are the complications which commonly occur during TAVR. In our patient, the patient was 65 years of female patient, came with the giddiness on mild to moderate exertion for 1 year. NYSA classification 3, class 3, Euro score was 2, and SDS prompt score was 6%. Echo finding were severe aortic stenosis with the gradient of 140 millimeter mercury. It was a bicuspid aortic valve, severe calcification with aortic size of 32 millimeter. On examination, there was systolic murmur radiating towards the carotid with visual sound. Rest of the systems were normal. On airway examination, the mouth opening was adequate and Mallampati score was 1. After a thorough pre-anesthetic checkup, we discussed with the whole team, and the surgeon and perfusionists were informed. Cardiopulmonary bypass was ready with dry reservoir. Injection phenylephrine 100 mics per kg was kept ready. All the GA drugs were ready. Emergency cards were prepared. All the ASA standard monitors were attached, and a patient was given with oxygen with 5 liters. Left radial cannulation done. Right internal jugular vein was placed, and external defibrillator pads were attached. A baseline ABG and ACT were normal. Inotropes were started at the minimal dose So in this patient, I gave dexmedetomidine at a loading dose of 1 mics and continued with 0.03 milligram. Injection fentanyl was started with a minimal dose. So we need to give heparin before balloon annuloplasty at 150 international unit per kg to achieve the ACT of more than 250 seconds. So during the procedure, this video is a video for the rapid ventricular pacing, where there is maximum hemodynamic alteration. The systemic blood pressure went to 40 to 50 millimeter mercury systolic. And the second one is the inflation of the balloon and placing the valve. Okay. And this is the valve. So challenges which we encountered in this patient are bicuspid aortic valve. Patient became uncomfortable while during induced AR while passing the guide wire. There was a transient hypotension. Patient became symptomatic with nausea, with complaining of nausea. Patient was treated with phenylephrine and NORAD. There was hemorrhage, so we need to transfer the patient for 4 units of PRVC. To conclude, successful management of TOWER included team approach, proper understanding of the anatomy and pathophysiology of the aortic stenosis, meticulous pre-planning and coordination of all the specialists involved in the hybrid catheter laboratory. We have successfully managed TOWER in the case of severe aortic valves, bicuspid aortic stenosis for the first time in the entire Northeast India. Thank you.
Thank you, Dr. Taran, for your very elaborate presentation. And please stay back till the end of the session. And the question and answer portion will be taken up after the completion of the 4 presenters. So please bear with us because of the time concern. We thought it would be better to take up in the last after the session of the completion of the session. Now I hand over the mic to my co-chairman, Dr. Guneshwar.
Next topic is on elbow instability. So I call upon Dr. Lachar, orthopedic and Thomas Ras Majestity, to start the presentation.
At the very outset, I would like to pay my respect to my elders, my teachers, my seniors, and colleagues and friends. I'm standing here in Manipur in a particular occasion after 30 years. I was away from this state. So this is partly an introduction of myself to all of you. I'm presenting on elbow dislocation and instability. We have got a mixed population of audience. It may not be of good taste to many, but I would like to make it a little interesting as far as possible, and I will just run through because time is very less. It's very common, and more than half is occurring in adolescence. This dislocation is a very challenging thing even for a very experienced surgeon to give a very good result after the treatment. Even the mechanism is debatable till today. During our student time it was different. Every day it is changing. So today I'll devote on understanding the mechanism with proper assessment. Let me come to the types. There is simple dislocation where there are no bony fractures, but it can be very small, say less than 2 millimeter in diameter. But if it is complex, it contains bony fractures, and there are many configurations of fractures, as we all know. The incidence, these are US figures, 5.21 per 1 lakh population. It may be little more in terms of complicated means bony fractures. Male predominance is there, more than half or nearly half is in the second decade, and the commonness is while falling from a height, standing height. and sports injuries are also their commonest, being American football. We'll come into the restraints which stop dislocation. Primary and the secondary restraints are there. Primary static restraints being ulno-humeral articulation. This is very important. It is a very firm and articulation, very good congruent articulation, and lateral ligament complex, lateral collateral ligament complex, and medial collateral ligament, particularly the anterior band. Secondary stabilizers, here we have the radial head. It is not very good stabilizer, so it comes under secondary. Anterior capsule, musculotendinous structures, including the extensors, common extensors and flexor origins, and all the muscles traversing the joint, like biceps, triceps, etc. Now, here I would like to mention you that the ulno-humeral, it is very good, it gives good constraint because 170 degrees of articulation is there. And then in contrast, on the lateral side, radial head just covers an arc of 90 degrees. So there is greater importance of soft tissue structures on the lateral side. If we come to the bony constraints, it is good if we know the three-column concept. This is very new. I took it from a paper of this year only. The medial column is formed by the medial half of coronoid flexure and trochlea, medial trochlea. Middle by the lateral half, anterolateral coronoid, and the lateral trochlea. And the lateral column is by the radius and the capitulum. There is a fulcrum, this is very important, which is between the anteromedial and the medial, means middle. It is on the ridge of the coronoid. The medial column is the only bony restraint in varus collapse. Medial collateral ligament complex, let us see. Here we have anterior band, posterior band, and they describe a transverse ligament also. Now, the anterior band is very important. It gives stability throughout the flexion arc. It gives valgus and the posterior medial stability. And let me come to the posterior band. It's primary in providing rotatory stability, just like your PL band in ACL. And it plays greater role in stability in the context of associated injury. If we see associated injury, this has become important. This is only a recent sort of development. And if the elbow has to dislocate with good displacement, this ligament has to get torn. Now, here are some pictures. Medial epicondyle, then the sublime tubercle. I don't know if we have a pointer, it should be better. And then here is the dissected specimen. Now, here I would like to tell you that when we extend the elbow, the anterior band becomes taut, and when we flex, it is the posterior. So we use this in terms of testing as well as in terms of treatment. During throwing, in maximum of the throwers, when we see, you see there is valgus torque of about 64 Newton meters. But ulnar collateral ligament strength is about 34 Newton meters only. So about half only it handles. The remaining half of the torque is handled by all the musculotendinous units. Here we see the phase in throwing, the leg cocking, the early acceleration. Here the ulnar collateral ligament is active. In the leg cocking, it is the posterior. In the early acceleration, it is the anterior band, which is important. And when the ball leaves the hand, here comes the importance of our valgus extension, injuries. Lateral collateral ligament. Diagrammatically, it is okay, everything is clear, but during on the operation theater is not very much like this. what is very important is lateral ulnar collateral ligament, which is the main thing. This is a primary stabilizer. But of late, there is much interest given to the posterior stability. There is a ligament, posterolateral ligament, which was not even described during my student days. Now, if it is injured, there is, it is again, the name is given Osborne collateral ligament. If it is injured, posterior stability is lost. So this is the paper, if somebody is interested. And this is the CT scan. Here, the bony avulsion is seen here from the back of the capitulum. It has to be fixed. Common flexor and extensor origins, these are very important, as I have already told. Jefferson's study, he describes that disruption of common flexor and extensor origins are important determinant of instability after simple elbow dislocation. This all of us as clinicians should know. If my simple dislocation has to be treated without surgery, I have to make sure that both these muscle units are okay. During supination, it stabilizes the MCL, and during pronation, it stabilizes the lateral ligaments. These are also important during our testing as well as when we put the limb into immobilization. This is the mechanism of injuries. Let me simplify it. Posterolateral, this is the terrible triad, as we all know. Valgus external rotation is the mechanism. Here the injured structures are lateral complex ligaments, radial head, and anterolateral facet of coronoid, not the anteromedial. Posteromedial rotatory instability, here it is varus internal rotation injury. Here again, lateral complex ligaments are torn, anteromedial facet of coronoid here, posterior band of medial ligament. This is again has to be highlighted. Montesia fracture, Montesia fracture dislocation, axial and bending. Here we have to know that anterior, if the apex is anterior, that is radial head dislocation, in apex posterior we get radial head fractures. Simple elbow dislocations are classified by the olecranon directions. What is most important is posterolateral. It is posterolateral and posterior, it constitutes 90%. Posteromedial is only 10%. So let us devote on the posterolateral. Is the mechanism. O'Driscoll et al., they describe a Horry circle. Means the injury starts from the lateral ligaments going towards the medial ligaments. Now, another theory is hyperextension and valgus theory. This is proved by MRI studies. This is a recent study. Here the MCL means medial side fails first. Then after that lateral ligament, then common flexor origin, so on and so forth. Now if the instability is there, instability incidence is about 3 to 8% after all the injuries. Posterolateral rotatory instability, these are graded into grade 1 and 2. When there is drawer test is positive and a pivot shift test is negative, then that is grade 1. Here the isolated posterior ligament avulsion will be there. In grade 2, all are torn, but there can be still posterior ligament may not be involved. Here drawer as well as pivot shift will be positive. They give progressive lateral degeneration. Valgus extension overload VO. This is, as I told you, when the thrower lifts the ball, throws the ball, when the ball lifts the hand. So the mechanism here is valgus stress, and risk factors are there who get such sort of problems. And when we examine, there will be some impingement on the medial aspect of the tip of the olecranon. And repetitive uses, it gives rise to MCL failure and so on and so forth. This is the paper. I'm sorry. There is time is up. Fracture dislocations, actually, if we follow Wrightington classification, here it gives how it has to be treated also. If we follow this strictly, it is easier. And I would like to tell our orthopedic students also, kindly use this and see. This is very easy, and it is more effective, and it will give you less chance of sort of mistakes and failures. Just running through, there's no time. I want to conclude that elbow instability varies. Surgical interventions restore to they aim to restore stability. What is most important is to be a successful clinician, understanding the pathoanatomy, the mechanism, and the process, how to assess that. Thank you very much.
Thank you, Dr. Lachab. It is a very complex topic. You have made it very simplified. So the next speaker is Dr. Chauba, Associate Professor, Department of Anesthesiology. He will be speaking on ultrasound as a bedside tool.
So excuse me, for the convenience of the delegates and to save time, I request the speaker to maintain the timing allotted to you.
A very good afternoon, afternoon to respected chairpersons, my seniors, sisters, and colleagues. Like I'm standing here not as a sonologist or cardiologist. I'm standing here as a doctor who wants to popularize ultrasound to all the periphery doctors. And I want to thank the organizer of the MMA Con for giving a chance to talk on this topic of ultrasound as a bedside tool. And we all know that the basic skill of the ultrasound, I'm telling you again, basic skill of the ultrasound is very simple, straightforward, and main advantage of ultrasound is it can be repeated again and again, and there is no radiation risks. And then it's not like portability is another thing. It can be done at the bedside, not like CT or MRI. So having this thing in my background, I want to make this one as a very popular tool for the bedside. So why we use ultrasound? We can use ultrasound to assess the cardiovascular system, respiratory system, abdomen, CNS, and even for the peripheral vein cannulations. I don't know how many of us has done this under peripheral vein cannulation. So we know that cannulation of the vein is easy, straightforward. If you see a vein like this, it's straightforward. But if you see a patient like this in the ICUs, where lots of edemas are there, and some like air-based pictures are there, and some VIPs will be a bit obese, where you don't want to poke again and again to get the line. So here comes the role of ultrasound. And another thing is, after putting the line, that part of the line might be okay, but what about the proximal part of the vein, whether it's patent or not? That's another thing we want to see it. So see, how we see the ultrasound, how vein looks like in the ultrasound. You just, sorry, okay, video not playing, okay. So you just compress the here is the thing, vein, you just compress over it, and it vanishes, just that vein is collapsible. And if it is something like this, yeah, my video is not playing, that's the issue, I'm very sorry. So here is a thrombus there, when you try to press it, vein won't be collapsing. And if I put a color here, and it will be almost obliterated. So even though vein there might be patent here, and in the proximal segment, it might be obstructed. See, this is the thing with the helper ultrasound, we can find out whose vein is patent and where to start. So use of the ultrasound in the peripheral vein cannulation is very good. I don't know, videos, sorry. Okay, so I put the line here with my cannula coming there in the vein, and this long axis, the short axis view of the vein, and the long axis view of the vein. So I can see the thing there, but my video not playing. Yeah, so after putting the line, the cannula looks like this. Okay, so another use of the ultrasound in post-op period. I just want to highlight here, see, this is the brain. This is 2 weeks back we have done the case. Already the craniotomy done. There is a window in the brain, window in the cranium. This part of the brain is empty. I mean, the cranium is not there. So put the probe here, you will see like this. So this is the ultrasound image. So I can see the midline, and if you look closely, you can see some part of the SDA is also there, which is there. Okay, and yeah, I mean here, SDA is there. And if you, yeah, you can see the ventricle there. So this is the corresponding CT cut of the patient. So if you got a bone window, always you can put a ultrasound probe there and see at least if the patient deteriorates, I can just see it, whether the midline shifted or not, big hematoma coming or not, so I can have very fast on the bedside, I can detect before shifting the patient to the CT scans. Another Netesu has talked all about the recurrent laryngeal nerve, this thing, that thing. Here, okay, video not playing. So here I want to show you that vocal cord we can assess with the ultrasound, more so with after the thyroid surgery. In the era of COVID, we don't want to see with the laryngoscope or the indirect laryngoscopy, put there in the mouth, see and tell our patient, say, make some noise like E, like that, so that we can see the vocal cord movement. But with ultrasound, you put over the thyroid cartilage, focus it, you can see the vocal cord, and you can see the vocal cord movement there. So yeah. Oh, sorry. Yeah. Yeah, here's the bowel movement in the post-op period. See, instead of listening to with the stato, you can see exactly with the ultrasound. See, this is the bowel. I will play again. Look closely here. Look closely here. This is the bowel movement there. Is the bowel movement. So sometimes it's very handy ultrasound in the post-op period. When you assess, when I go for a round, the ultrasound should be there in the ICU. That helps me, that gives lots of information to me. Okay, we all know that ultrasound is very useful for assessment of psych. So we can see the IVCs or preload, we can see the contractility, the pump, the heart, or the pipes, or the aortas. So is there any fluid volume deficit in the tank or IVC? I can see from this is IVC, I can see from the IVC. IVC is full or collapsed. If it is collapsing or half full or half collapsing, then we can give the fluid. And see the heart, if you want a good contractility, no pericardial tamponage, so heart might not be the cause, or it might be cardiogenic shock or not, we can rule out easily there. Or we can see the pipes or the aortas, any aneurysms and ruptures, we can see from the thing. So we can classify or see all the types, 3 types or 4 types of shock by the ultrasound at the bedside easily. This is, I'm telling again, I'm not a sonologist again, I'm telling again. This you can learn in like 10-15 minutes. You have to have a good view, that's all. I'm not going to measure anything. I'm going to do all the eyeballing. I'm not going to measure anything of the chambers, this thing, that I'm not going to measure it. But by eyeballing, you can catch up many things with the ultrasound. Yeah, this is very sad. This patient, I came across almost 10 days back. This post-COVID patient was apparently all right. All right means like patient was intubated, COVID negative, intubated, maintaining saturation around 97, 98 with oxygen of around 70%, invasive ventilation, already tube was there. One day, early morning, around 7:30 a.m., they called me up, patient saturation drops around 60s. A bit tachypneic, a bit tachycardic, a bit hypotensive. While I was driving from home, I was thinking, what could be the cause? My tube is the malposition, or tube not in proper position, or intubral intubations, or some pneumothorax because the patient was with a COVID and the ventilation keep on going, or is something like pulmonary embolism, which is common in the COVID patients. So as soon as I read it, this is the thing, I did it. I put a prop to the linear prop to the trachea, this one, neck. I can see two rings there. So my tube is in the trachea. That much I can say. And then I started scanning my lung. Oh, again, if you see here, I'm going to come there. Yeah. So if you put look closely, you can see the lung movement there. This is up to intercostal, this rib intercostal muscles. This is the lung movement. So there is sliding of the lung there. That means there is no pneumothorax. So there is no pneumothorax. Then comes so there is no pneumothorax. Then when I scan the heart, I can see the right ventricle was a bit dilated. Then put a color on the tricuspid, I got a jet flow of the color down there. Scan the IVC, fully dilated. Scan the femoral vein, one big thrombus sitting on the femoral vein. So it hardly takes for me 5 minutes to scan the patient and diagnose this patient has got pulmonary embolism without doing a CT angio. It's possible with the ultrasound. This is accuracy of around 98%. Again, another use of the ultrasound, the bedside lung ultrasound in emergency for those patients coming with hypoxia. We can diagnose pulmonary edema, pulmonary embolism, pneumonia, COPD, pneumothorax. We can all do with the ultrasound. Another very interesting with all the neurosurgeon, ICP measurement with the ultrasound, possible. Put the probe on the eye, above your eyelid, measure the optic nerve sheath diameter. If it is more than 5, ICP is roughly correlated with 20 millimeter mercury. Even tracheostomy I do with the ultrasound. Trauma, we all know that first scan. All surgeon knows it this. First scan, four quadrants, hepatorenal, splenorenal, or the subcostal and the pelvic area. You can scan it. Any blood there, patient shock, any blood there, then reason for opening the abdomen. So miscellaneous use. This will be the most interesting part. We all know that we put the Foley's. We come across many times inability to deflate the pilot balloon of the Foley's catheter. We come across lots of them. If the patient is there for almost 10, 20 or 30 days and the one who inflates the balloon with the saline, then is going to block it all the thing. So with the ultrasound, what we do, put in the pubic area, puncture with the spinal method, will be easily removed. That's one. Another use of for ultrasound in the catheterization, sometimes we are very doubtful whether the catheter is fully inserted or not. Put the ultrasound probe, see the balloon there. That's all. This is very simple. So to conclude, I want to propagate, or I want all the clinicians to learn at least some basic ultrasound. And ultrasound is not only for sonologists, cardiologists, or intensivist gynecologists. And I suggest that it should be incorporated in the undergraduate protocol. At least some basic ultrasound ideas should be incorporated, like we use a stato in the clinical realm. Thank you very much.
Please stay till the end for the question and answer. The last speaker of this session is Dr. Banasri. She'll be talking on role of flow cytometry in management of leukemia. Dr. Banasri.
Good afternoon, everyone. Let me start my talk. That is, the topic is role of flow cytometry in the diagnosis and management of acute leukemia. I can start my talk with the classification of acute leukemia. The acute leukemias are classified into myeloid and lymphoid leukemias. And according to WHO classification, we need at least 20% blast count, either in the peripheral blood or the bone marrow. And moreover, we need to identify myeloid blast from the lymphoid blast because we need quantification for the diagnosis. So the identity of this blast identification of this blast can be done by morphology or cytochemical staining of the bone marrow aspirate or the peripheral smear, but morphology alone is difficult to confirm most of the time. Again, the cytochemical staining using MPO and the Sudan black, which are said to be positive, which is most of the time positive on the myeloid blast. Again, it is negative on AML M7, AML M0. Again, PAS, which is another special stain used on lymphoblast. Again, it is not always positive on the lymphoblast. Acid phosphatase stain, which can help in the identification of T lymphoblast. Again, it is positive on one mature B cell lymphoma, that is hairy cell leukemia. So, for identification also, we need flow cytometry. In this scenario, we need flow cytometry. Flow cytometry is the measurement of cellular property in a fluid stream. The basic principle is the cell flows in a single stream in front of a laser, then where it is detected, counted, sorted, and analyzed. And it is the component of a flow cytometer. As we can see here, the cells are flowing. The pointer. Okay, I can use the cursor. I don't know. Yeah, the cells are flowing in a single file, and the laser beam is coming perpendicular to this flow. Here they are analyzed, sorted, and this is the photograph of a flow cytometer. Now coming to myeloid blast versus lymphoid blast. We have certain markers. For myeloid markers, we have these markers, then monocytic markers, megakaryocytic markers, B cell markers, T cell markers. Sometimes some chronic lymphoid neoplasms like Burkitt lymphoma, diffuse large B cell lymphoma, prolymphocytic leukemia, they have blastoid morphology. For this, we need to assess the expression of immaturity markers like CD34 and TDT on the suspected cells and see whether these are expressed or not. If they are expressed, then this is acute leukemia. If they are not expressed, then we have to rethink. Then in the classification of acute myeloid leukemia, according to WHO, we have certain categories. And amongst this category, we have this AML with recurrent cytogenetic abnormality. And amongst these, again, we have these 3 categories which have got good prognosis. And remaining, they have a poor prognosis. Among these good prognosis ones, there is one, acute promyelocytic leukemia. This is a malignant disease, and it is a medical emergency because this disease is associated with disseminated intravascular coagulation and increased fibrinolysis. For this, we have to have a prompt diagnosis. And this particular leukemia has 2 morphological variants. One is hypergranular variant, this one, which nobody will miss because it has got a characteristic cell morphology, so nobody will miss. But what about this microgranular variant? This microgranular variant, most of the time, or some of the time, we may confuse with AML with monocytic lineage. So if we make the mistake, then the patient has to pay heavily with his or her life because it is an emergency. Patient will die, if we don't identify, diagnose, treat properly. And for this, flow cytometry comes to our rescue. In this particular entity, there is a characteristic finding on flow. We have homogeneous expression of CD33 along with heterogeneous expression of CD13, 117, absence of CD34 and HLA-DR. Let me show you a plot. Here, these are the promyelocytes, these red dots. These are the promyelocytes. They are having, falling in the blast gate, but they are having a high site scatter because of the high granularity. And these promyelocytes are homogeneously positive for CD33, heterogeneous for CD13 and 117, and absence of CD34 and HLA-DR. So this cleans the diagnosis. As I have told you, this particular acute promyelocytic leukemia, they have a good prognosis if we treat properly, if we diagnose properly. But there are some markers like expression of CD2, expression of CD56. Again, these are associated with poor prognosis. So flow cytometry, in short, helps in the prognostication also. Then coming to B lymphoblastic leukemia, it's a dot plot. Here, the blast, the red color ones are my blast. As I told, this particular blast usually have low site scatter, and these blasts are expressing CD79A, then 10, and CD19. So it's a B cell acute leukemia and CD34 immaturity marker. And in the classification of BALL, according to the latest 2016 WHO, we have certain categories. Again, BALL with recurrent cytogenetic abnormality. Again, I have given, these are the entities. Those in blue color, they have a good prognosis. Those given in red color, they have a poor prognosis. And let us discuss BALL with hyperdiploidy, BALL with hypodiploidy. As we can see here, one is having good prognosis, another one is poor prognosis. In this, we usually do karyotyping. This is one karyogram of a hyperdiploid ALL. But karyotyping, it's time consuming. It takes weeks together. So we cannot wait for weeks together for redefining the treatment. So in this case, flow cytometry can replace. So cell-ploidy analysis on flow, again, the analysis can be done by seeing the DNA index. Again, it is cheap, fast. We can expect same-day reporting. And some cases of BALL, like BCR-ABL1 or KMT2A rearranged cases, they have poor prognosis. Flow cytometry can again give a soft pointer, like co-expression of myeloid antigen on the blast along with the lymphoid antigen. Then we definitely have to do BCR-ABL1 mutation analysis. And likewise, detection of NG2 homologue, again it is characteristically expressed and specific for this particular entity. Again, a new entity that is BALL, BCR-ABL1 like. It is a new entity, it has got a very graph prognosis. Here, detection of CRLF1, CRLF2 by flow cytometry, it is specific and it can be used as a screening method. Again, amongst the TALL, there's a new entity that is early T-cell precursor lymphoblastic leukemia, ETP-ALL. Again, it has got certain criteria, diagnostic criteria. It is solely dependent on the flow cytometric finding. Again, ambiguous lineage, MPAL. Again, the criteria are these for diagnosis. Again, here it is dependent on the flow cytometric finding. Again, this is a dot plot of a MPAL. Here the blast, that is red color ones, they are having CD34 expression along with 19 and MPO. Again, after the treatment is started, we need to follow up the cases with MRD, minimal residual disease analysis. Again, these are the methods, and in most of the centers, flow cytometry is the usual method that is employed for this. There are certain approaches. Detection of leukemia-associated immunophenotype, LAIP. Again, this can be cross-lineage antigen expression of lymphoid on myeloid. It's something like a dog or a bird having a dog face. So it's a unique type. Or it can be asynchronous antigen expression. Some antigen which is not expected is expressed. It's something like this. So again, antigen overexpression or underexpression can also be used as an approach to analyze the MRD. Again, it is something like this. So why MRD analysis in case of BALL? Because current treatment strategies in ALL provide long-term remission in more than 90% of the cases, and risk stratification based on MRD helps in redefining the treatment. Again, in some center, like PGI Chandigarh, we usually do blast count on day 8, followed by MRD quantification on bone marrow, post-induction on day 29. And these are the set of antibodies used for MRD analysis. And AML MRD is an upcoming topic, and most of the center, some center I should say, not most, some center in this country, they have undertaken this. They are regularly doing it, and these are the markers used. And it's one case study here. We have gathered the CD117 positive cells, and these cells, we see the expression of CD13 and 33, and those having a bright expression of CD13 and 33, they are the myeloid regenerating blast. And here, these are our cells of interest, which are CD33 negative, 13 negative. Okay. So ultimately, we remove the erythroid blast, and these are our cell of interest. This is the calculation thereof, and advantage of, there are certain advantages and disadvantages of, then another application of flow cytometry in the management of acute leukemia is the stem cell enumeration, because stem cell transplantation is needed for some high-risk group. For this, we can do stem cell enumeration. These are the dot plot. Other applications are, sometimes the patient may have severe thrombocytopenia, which is difficult to count even on manual method. That time we can use flow cytometry to count the thrombocyte, the platelet count, and to check the response to treatment after antibody therapy like blinatumomab, or assessment of cerebrospinal or body cavity fluid in case of suspected relapse cases. Thank you all for your patient hearing.
Thank you, Dr. R.K. Vanasri, for your nice informative presentation.
Now the session is open for question and answer, and we would like to permit only one question to one particular speaker. So please.
Vanessa, what is the status of acquiring this flow cytometry? Because 1.5 years ago, the then health minister was interested to procure this. So there was some communication with you and our director. So what is the present status?
Sir, it has remained stagnant actually in Genim.
Stagnant. no more advance.
Yes,
Oh, for the last 30 years I was trying to procure this through DBT and I could not succeed.
Sir.
Since there is no more question, we would like to end the session, and I would like to thank all the speakers for their nice presentation, and also the delegates who have been still making the program lively and interesting. And with these few words, I thank all the delegates as well as the speaker. Now I hand over the mic to the organizer for continuation of the next program.
Thank you, sir. Now we will have a felicitation, but before that, I'm really sorry to all the invited speakers. You have spoken very nicely. All the talks were informative and very interesting. We are not doing justice by giving you only 10-12 minutes. In fact, this Amamicon 2020, we had 55 free papers, 10 invited papers, 2 orations, and 4 CMA. So we had lots of talk. That is why we are not able to give you more time. Next year, probably we may give you more time. We are so sorry for that. And to felicitate our speakers today, I would like to request the chairpersons, Sir S. Manikanto, sir, to kindly felicitate our first speaker, Dr. Charan. Photo. Asyik kunjalo. Our second speaker, Dr. Laj Saif from Ras Medicity. Thank you, sir. Next, I would like to call upon our next chairperson, Dr. Orguneso, sir, to kindly felicitate Dr. L. Chauba. Down photo. Thank you, sir. Next, I would like to call upon Dr. Thor Behendes, sir, to kindly felicitate Dr. R.K. Banasri, madam. Thank you, sir. Now, we will felicitate our chairperson, and we are very lucky to have among us Dr. Sukuma Namaram, and he is 94 years of age, and he is a very active member of IMA. He has never missed any IMA conferences, and we are blessed to have him today around us. Let us give him a round of applause. And thank you, sir, for coming. Sir is 94 years of age. Basanta, First, I would like to call upon our first chairperson, Dr. S. Manikanta, sir. Sir, please. Sir, Guneshwar, sir. Chato Igondu, sir. Thank you, sir. And we have sir, we'll have a group photo. I'll also. Thank you. We will also have the privilege to felicitate, sir. Please. Oh, the president of the IMA will felicitate, sir. Sir Depiro, sir. Yeah, Sir Mohan, please felicitate, sir. Thank you very much, sir. Sir is also the first MBBS doctor of Manipur. Let us give a standing ovation for sir, please. Now we are going to have the much awaited program, much awaited part of Amamicon 2020, the prize distribution of award sessions. We have 3 award sessions. One is S. Yuvavati Memorial PG Paper Award Session. Second is Tampak Lema and the K.H. Itosa Award Session. And the Best IMA Poster Award. So to do the honor, I would like to call upon the President of IMA, Dr. Sir Sam, to kindly give away the prizes and announce the winner.
Hello, yeah. The most awaited S. Jubavati Memorial PG Award, we have 3 prizes, first, second, and the third. The third prize goes to Dr. Rachiel. Dr. Rachiel, congratulations. We'll be handing over certificate later on. Yeah, we are giving a token of appreciation. Congratulations, Doctor. And all the best in your life.
Second place. First certificate.
S. Yuvavati Memorial PG Award. Second prize goes to Dr. Singh Tombing.
Dr. Rachel got 86.5 marks, Tombing got 90.4 marks.
Congratulations. All the best. All the best in your life. Oh, yeah.
And best.
The best paper for this Juvapati Memorial Award goes to Dr. Anyone could guess? Anyone could guess? Yeah, Dr. Kansana Lyson, Department of Orthopedic Journals. Congratulations.
She scored 96.5 marks.
I think you must be the first orthopedic surgeon in Manipur, lady orthopedic surgeon. Then you are, you are a pioneer. So congratulations, kindly accept our token. And all the best in your profession and your life. Congratulations.
Yeah, so let's see control here. Next, I would like to call upon our Vice President, Sarjogan Rasa, to hand over the Best Post-PG Best Paper Award, Tampak Lema and Itocha Award, sir.
So it is my proud privilege to announce the Tampak Lema and KH Itosa Award. There are only 2 awards for this, the first and the second. The second goes to, with a big round of applause, congratulations to Dr. Pausyam. Congratulations and all the best future. Very good. And Tampak Lema and KH Itocha Award, the winner of this contest is, again a big round of applause for Dr. Tina Das. Congratulations to Dr. Tina Das. Congratulations. It was excellent presentation. Congrats. All the best. All the best.
Next, I would like to call, thank you, sir. I would like to call upon the Honorary Secretary, Dr. Arun Kumar, and the Chairman of Scientific Committee, Dr. Salam Randu, to kindly hand over the prizes of IMA Best Poster Award. prize goes to Dr. L. Russell. Dr. L. Russell. Okay. Not there? Okay. See, the second prize goes to Dr. Ramji. Not there. And the best IMA Best Poster Award goes to Dr. N.G.B. Kumar. Thank you, sir. This comes to the end of the scientific program in the main hall. Thank you, everyone, for your patience.